Hey everyone. So, I'm first of all, I'm very sorry for the delay of these few months. I've been busy with some personal stuff and job and everything. But now that I'm back, I have done the Uworld annotations of all the organ systems, and I will also let you know where there is Uworld annotation or any other QBank annotation along with the first aid. So uh, it gets a little bit easier while solving the UWorld notes, so that you are already aware of the any new concept that is not in the first aid but it's in the UWorld, right? So let's get started. So we are doing the respiratory system, and a few days after this video is being uploaded, I will also upload the endocrinology part because I'm also done with that system. Okay, so let's start. So the first section is embryology. Let me select a different color this time. I've been told that the red color is getting a little bit boring in every videos, so this time we are going with, I guess, the green color. Okay, this one is fine, right? No. Okay, I think we can stick with the blue one. Okay, so embryology. So the lung development occurs in 5 stages. It begins with the formation of lung bud from the distal end of the respiratory diverticulum during week 4 of the development. And there are 5 stages. So every pulmonologist can see alveoli. That is the mnemonic for all of the 5 stages, right? So it occurs from the distal end of the respiratory diverticulum. If this is the respiratory diverticulum, so this is the distal end, that is the distal end of the bronchi. From that, both of the lungs will develop, right? The first stage is embryonic stage, that is week 4 to week 7. And the bud that we saw, lung bud, that the first of all the lung bud develops, then the trachea develops, then bronchial buds develop, and then the main stem bronchi, secondary bronchi, and tertiary bronchi. Okay, the secondary bronchi is also called lobar bronchi, and the tertiary bronchi is also called segmental bronchi. An error at this stage can lead to tracheoesophageal fistula, right? If the trachea fails to form or the bronchial buds fail to form, they can have a connection between the esophagus and the trachea, or esophagus and the bronchi, and that is just the TEF, right? The second stage is pseudoglandular stage, and the endodermal tubules turn to terminal bronchioles, and it is surrounded by the modest capillary networks. And the respiration is impossible at this stage, and the fetus, if born, it is incompatible with life, right? And canalicular, the pseudoglandular, so it looks like a gland, it is a pseudo gland, right? And third is canalicular, the terminal bronchioles turn into respiratory bronchioles, and respiratory bronchioles turn into alveolar ducts. Mind you, alveolar ducts, not the alveoli itself. It is surrounded by prominent capillary network, right? So we all know that alveoli are surrounded by the capillary network for the gas exchange, right? So the capillary network starts to become more prominent around the alveolar ducts and alveoli. And airway increase in diameter. Pneumocytes develop starting at week 20, and respiration is capable at 25. Fourth stage is secular. So sacs develop, that is terminal sacs develop. Alveolar ducts turn into terminal sacs. So this is the alveolar ducts, and this is the terminal sac. And terminal sacs are separated by the primary septae. The last stage is alveolar septae. Terminal sacs turn into adult alveoli. That is due to secondary septation. In utero, breathing occurs via aspiration and expulsion of amniotic fluids. right? There is no air, there's just amniotic fluid, and it increases pulmonary vascular resistance through gestation. Right? At birth, air replaces fluid, so that decreases the pulmonary vascular resistance level. Because now let's see if these are the lungs. We have previously discussed this in, I think, cardiovascular system, that if there is amniotic fluid all in the lungs and the respiratory system, or if it is air, so fluid will always have more pressure and it will always offer more resistance. So if there's amniotic fluid in the respiratory system, there's going to be increased pulmonary vascular resistance as compared to the air in adult life, right? Now let's simplify all this, because this is very difficult to remember. So now first let's simplify the weeks, right? So if this is 4 to 7 weeks, we can say this is 4 to 6 weeks. This is 6 to 16. This is 16 to 26. And this is 26 to birth, right? So 4 to 6, 6 to 16, 16 to 26, and 26 to birth. Right, and the alveolar stage is continuous stage in adult life too, right, till 8 years of life. And I have personally developed a new mnemonic, that is TTA, TA, right? So this is like that AT sequence in biochemistry that we saw, or you can just remember T, Tata, T. There's in India there's Tata tea, if you guys know. So this is just opposite of it, that is T, Tata. So the first stage is tertiary bronchi develops, right? So in embryonic stage, in embryonic stage we saw tertiary bronchi being developed. Then there is, I think I might stick to just the red color because I think it is a sharp color and that can be seen very easily. Blue is just not the color for me, sorry guys. So tertiary bronchi becomes terminal bronchi, and then alveolar ducts, and if the duct has developed, then there is just one thing to be formed, that is terminal sac, that is alveoli, and then adult alveoli. So T, T, A, T, A, right? So now in the embryonic stage, the tertiary bronchi is being formed. In the pseudoglandular stage, terminal bronchi is being formed. In canalicular stage, alveolar duct is being formed finally. And in saccular stage, terminal sacs are being formed, right? And in alveolar stage, there is adult alveoli being formed, right? So this is embryonic stage, this is pseudoglandular stage. Alveolar ducts are also, remind you that alveolar ducts are formed along with capillary networks, right? So that is canalicular stage. The name itself suggests, right, it is a canalicular stage. So the canals are being formed. So what are canals? The alveolar ducts are the canals, and saccular is terminal sacs are being formed, right? The names give it away. And in terminal sac, there is also primary septa. Terminal sacs, the immature alveoli are separated by the primary septa, and the adult alveoli are separated by secondary septa. Right. And also, if the saccular stage is being disrupted, that is, if the terminal sacs are being disrupted, we have a disease called bronchopulmonary dysplasia. Right. And you can also check this diagram out, but I don't think it's necessary after all that we've discussed, right? So let's move on to coronal atresia. And yeah, there's one more thing about this surfactant, that the surfactant starts forming by 20 weeks of gestation. It peaks around 38 weeks. That is at the time of the birth or immediately after birth, and it starts declining as the kid grows up till 8 years, right? And respiration is capable at 25 weeks, after the terminal sacs are being formed in the saccular stage. So as surfactants are being formed after the pneumocytes start developing at the week of 20, right? Surfactants starts forming as soon as the pneumocytes are being formed. Now the coronal atresia. So this is just the blockage of posterior nasal opening, that is the corona. I don't know if I'm pronouncing it right, but just bear with it. Often associated with bony abnormalities of the midface, right? And it is most often unilateral, because if it is going to be bilateral, it is going to be a very fatal disease, right? And when bilateral, it represents an emergency, just like I said, and presents with upper airway obstruction, noisy breathing, because it is the breathing is done by the mouth, or cyanosis that worsens during feeding or improves with crying. Why does the cyanosis worsen with feeding? Right, because when the child is eating with the mouth is occupied for eating, right? And if there is bilateral obstruction, bilateral coronal atresia, we don't have any other option except breathing through the mouth, right? So cyanosis is being worsened during feeding, and it improves with crying. Diagnosis by failure to and it is diagnosed by failure to pass NG tube and confirmed with CT scan. And often part of the multiple malformation syndromes, such as Chard syndrome, which is coloboma of eye, heart defects, atresia of corona, and restricted growth and development, genitourinary defects, and ear defects, that is Chard syndrome. Now, lung malformations. So first is pulmonary hypoplasia, that is poorly developed bronchial tree with abnormal histology, and it is associated with congenital diaphragmatic hernia, usually left-sided, and bilateral renal agenesis. So if there is diaphragmatic hernia, that hernia is going to occupy some space, right? So it is not going to let the lungs develop properly, because the pleural space is being occupied with the loops of intestine, right? And the bilateral renal agenesis. So if there is renal agenesis, there is going to be less urine, right? And as we all know, that amniotic fluid is being formed from the urine, right? So the amniotic fluid is also going to be less, and if the amniotic fluid is going to be less, there is going to be less mature lungs, because amniotic fluids helps in maturing lungs. And second is bronchogenic cyst, caused by abnormal budding of the foregut and dilatation of the terminal or large bronchi. Discrete, round, sharply defined fluid-filled densities on chest X-ray, and it can be air-filled if it is infected. generally asymptomatic but can drain poorly. It can cause airway compression if it is a bigger cyst, and it can also cause recurrent respiratory infections. This is very low yield. Okay. Now the club cells. It is non-ciliated, low columnar slash cuboidal with secretory granules, and it is located in bronchioles. Degrade toxins via cytochrome P450 and secrete component of surfactant, and it is progenitor cells for club cells and ciliated cells. So club cells secrete a component of surfactant that helps in the formation of surfactant, and surfactant itself helps in formation of progenitor cells. It helps in the formation of club cells and ciliated cells. And they are non-ciliated. The ciliated cells also helps in removal of toxins and removal of bigger toxins from the respiratory system. And if it is a non-ciliated cell, it degrades the toxin via cytochrome P450. Right. Now the alveolar cell types. The first is type 1 pneumocytes, that is squamous, and it occupies 97% of the alveolar surface, and it thinly lies the alveoli for optimal gas exchange. If this is the alveoli, these are the type 1 cells. So it thinly lines the alveoli for gas exchange, and there will be a bigger type 2 cell in between, right? The type 2 pneumocytes that are cuboidal and clustered, they are not squamous. They are cuboidal and clustered. It has two functions. The first is it serves as stem cell precursors for two cell types, that is type 1 and type 2 itself, and it proliferates during lung damage. This is very important function, that it proliferates during lung damage. So there might be a question where they state that the type 2 pneumocytes are increased when seen on the histological slide, and that is probably due to proliferation during the lung damage. And the most important function is that it secretes surfactant from lamellar bodies. Right. The arrowhead in B. And surfactant, it decreases the alveolar surface tension, decreases alveolar collapse, decreases lung recoil, and increases the compliance. Composed of multiple lecithins, mainly dipalmitoyl phosphatidylcholine DPPC. So it is a kind of lecithin. Right. Synthesis begins at 20 weeks of gestation and achieves mature levels at 35 weeks of gestation. And glucocorticoids are important for fetal surfactant synthesis and lung development. Collapsing pressure is 2T/R, we all know that, and law of Laplace is alveoli have increased tendency to collapse on expiration as radius decreases. So as radius is going to decrease, the collapsing pressure is going to increase, and that will help the alveoli to collapse more. But to prevent alveoli from collapsing, if this is the alveoli, there is always going to be a inward pressure that wants to make the alveoli collapse. But as we have layer of surfactant, it is going to prevent alveoli from doing so. Right. And the third kind is there's one more thing, that there's a diagram in Uworld which suggests that lamellar bodies are a parallel stack of lamellar bodies. So it is not a single structure, right? It is not a single structure, but rather it is a parallel stack of lamellar bodies, right? So if this is the type 2 cell, it's going to produce surfactant which is which is being carried by the lamellar bodies to the surface of the alveoli. And so these are the type 1 cells, and through lamellar body the surfactant travels to the surface of the alveoli, where it covers it, right, to prevent the collapse of the alveoli. And the third kind of cells are alveolar macrophages. And yeah, one more thing. So surfactant is being used up by the alveolar surface, and when it is not needed or if it is in excess, it goes to alveolar macrophage for the clearance. So surfactant is being produced by type 2 pneumocytes carried by lamellar bodies, and then cleared by the alveolar macrophage when not needed. So alveolar macrophages phagocytose foreign materials, release cytokines and alveolar protease. Hemosiderin-laden macrophages may be found in the setting of pulmonary edema or alveolar hemorrhage. We will later on see how these hemosiderin-laden macrophages are being formed. Basically, there is excess of blood, excess of fluid in the alveolar space, right, in pulmonary edema and all. And the macrophages here gets accumulated with that blood, and the hemoglobin in that blood is being accumulated in the macrophages, which gives it a reddish brown type of color. And this protease is basically the elastase, right? Neonatal respiratory distress syndrome, NRDS. So there is surfactant deficiency, which increases the surface tension and causes alveolar collapse. Ground glass appearance of lung fields, which is so this is the ground glass appearance. You just have to see the images of ground glass on Google. Okay, just Google it out yourselves and see how ground glass looks like, because I didn't knew when I read about the ground glass appearance how a ground glass looks like. Okay, so the risk factors are prematurity, diabetes during pregnancy because of increased fetal insulin. So insulin inhibits the surfactant formation. C-section delivery, decreased release of fetal glucocorticoids in C-section delivery, and because it is less stressful than the vaginal delivery. So whenever there is stress during the vaginal delivery, fetal glucocorticoids are being released, right? And glucocorticoids enhance the formation of surfactants, right? Even in surfactant deficiency, we give glucocorticoids injections, right? And the treatment is maternal glucocorticoids, right? Before birth, exogenous surfactant for infant after birth. Therapeutic supplemental O2 can result in retinopathy of prematurity, intraventricular hemorrhage, and bronchopulmonary dysplasia, RIB. So the mnemonic is RIB, retinopathy of prematurity, intraventricular hemorrhage, and bronchopulmonary dysplasia. And the screening tests for fetal lung maturity is LS ratio, that is lecithin sphingomyelin ratio in amniotic fluid. So more than 2 is healthy, less than 1.5 is predictive of NRDS. And foam stability index and surfactant albumin ratio are also there, but they are very low yield. And persistently low O2 tension, so there is increased risk of PDA, right? Patent ductus arteriosus, because the ductus arteriosus gets closed due to the increased O2 tension. Like, whenever there is decreased pulmonary vascular resistance and increased O2 tension, the ductus arteriosus gets closed. So now, if there is low O2 tension, there is a risk of ductus arteriosus not being closed, that is PDA. And this is the graph which they can use in the question stem. Like at the 30 weeks of gestation, sphingomyelin starts getting decreased and lecithin keeps getting increased, right? So the ratio of lecithin to sphingomyelin increases, and if it is more than 2, it is healthy, right? And the orange part is at risk population, and the blue part is mature population, right? Now the anatomy part. The respiratory tree consists of two parts. That is, first is the conducting zone and the second is respiratory zone. So the conducting zone consists of large airway that consists of nose, pharynx, larynx, trachea and bronchi. Basically everything that is large. Airway, we know that alveoli aren't large, so they aren't in the conducting zone. And conducting zone just conducts the air to the parts that really matter, that is alveoli. And airway resistance is highest in the large to medium sized bronchi. Okay, mostly the medium sized bronchi. Small airways consist of bronchioles that further divide into terminal bronchioles, that is large numbers in parallel, so that offers least airway resistance. Right? Uh, we know, like in physics, we studied that the parallel conduction always offers less resistance, right? And the series conduction offers greater resistance. So basically these are the parallel bronchioles, right? So they will offer least airway resistance. And there's also a graph in Uworld, which is something like if this is the graph of resistance. I don't actually remember it very precisely, but it goes something like this. So at which point of respiratory conducting system the resistance is higher? So that is at the middle sized bronchi. Right. Let me see. Just leave it. I will not be able to find it right now. So what is the function of conducting zone? It warms, humidifies, filters air, but does not participate in gas exchange. That is anatomical dead space. And cartilage and goblet cells extend to the end of the bronchi. Okay, and pseudostratified ciliated columnar cells primarily make up epithelium of bronchus and extend to the beginning of terminal bronchi and then transition to cuboidal cells. Extend to the beginning of the terminal bronchi, so it is not exactly in the terminal bronchi, okay, and then transition to cuboidal cells. It clears mucus and debris from the lungs, that is mucociliary escalator. Airway smooth muscles extend to the end of terminal bronchioles and they are sparse beyond this point. Right. So if this is the bronchi, there is going to be cartilage and goblet cells here. And then if we go to the terminal bronchi, there is going to be pseudostratified ciliated columnar columnar cells. Right, pseudostratified ciliated columnar cells that extend to the beginning of the terminal bronchi. Sorry, my bad. So they are not in the terminal bronchi but extend till the beginning of the terminal bronchi. So they are also in the bronchi. Okay. And in terminal bronchi there is going to be smooth muscle cells. Right, we will see that in detail. We'll see this diagram. Right, and respiratory zone consists of lung parenchyma, and lung parenchyma consists of first respiratory bronchioles, alveolar ducts and alveoli. Just three things, right? And it participates in gas exchange. Okay, so mostly cuboidal cells in respiratory bronchioles, then simple squamous cells up to the alveoli. Cilia terminate in respiratory bronchioles, and alveolar macrophage clear debris and participate in immune response. Okay. So in respiratory bronchioles there is going to be cuboidal cells, and in alveoli there is going to be squamous cells. So now let's simplify what we just read. So first there is ciliated columnar cells, then and this ciliated columnar cells are in bronchi, the main bronchi. Okay, and then it ends at the beginning of the terminal bronchi. So in terminal bronchi we have ciliated cuboidal cells. So here we can see there is cuboidal ciliated cells in terminal bronchi. Then we have squamous cells, that is in alveoli. Okay, this ciliated cuboidal cells also extend in the respiratory bronchi as well. So nothing is specific to any part. Okay, all these cells are extended to overlapping parts. Okay. And in alveoli there is squamous cells. Right. So the shape of the cells at the beginning of the respiratory tree, that is in bronchi, is columnar, which goes on to form cuboidal and then goes on to form squamous. Okay. So let's see in detail. So in bronchi there is goblet cells for mucus production, right? There is going to be ciliated cells for mucociliary escalation. Then there's pseudostratified ciliated columnar epithelium, that is this columnar epithelium. As we saw, there are elongated columnar cells in the beginning of the conducting zone, right? Then there's obviously the smooth muscle and the cartilage. Now in bronchioles there is going to be club cells, right? So as we saw earlier that the club cells are progenitor cells. The club cells secretes a part of surfactant. That is, it secretes a component of surfactant. So there is club cells, ciliated cells in bronchioles. There is ciliated cells. There is simple ciliated columnar epithelium. Okay. In bronchi it was pseudostratified. Here it is simple ciliated columnar epithelium. And as we go down to the terminal bronchioles, there is cuboidal ciliated cells. Okay. And there are club cells as well as smooth muscle and simple ciliated cuboidal epithelium. So whichever cells that were columnar now is cuboidal. Okay, in terminal bronchioles. Now comes the respiratory zone, right? And yeah, so the ciliated cells are abundant in the bronchioles and the terminal bronchioles, right? They are not very abundant in the respiratory zone. There are cilia in the respiratory zone, but not that abundant. So the mucociliary escalation is only occurring in this part. Right? Let me just write that down. So if there is a pathogen or if there is any foreign particles, that is going to be cleared by mucociliary escalation of these two parts, right? Okay. Clearance is done by mucociliary mechanism. And the smooth muscles are also very sparse in the respiratory zone, right? They generally end in the terminal bronchiole section, and the cilia terminate in the respiratory bronchiole section. So in the respiratory bronchioles, cilia ends. So there is not much mucociliary mechanism in respiratory bronchioles, right? Rather, there is clearance occurring by the microphage cells. So there is clearance by macrophages. Right. So there are cuboidal cells, club cells, and now there are some squamous cells too, because as we are approaching alveoli, there is going to be squamous cells. Okay, and the smooth muscles are getting sparse. In the alveoli, the type 1 and type 2 pneumocytes and alveolar macrophage and the capillaries, right? So the squamous cells make up the type 1 pneumocyte, that is 97% of the alveoli. Right. Now the lung anatomy. So the right lung has 3 lobes and left has less lobes, that is 2, and lingula, that is homologue of right middle lobe. So instead of right middle lobe, we have lingula. And instead of a middle lobe, left lung has a space occupied by the heart. Relation of the pulmonary artery to the bronchus at each lung hilum is described by Raz. So right anterior and left superior. So in the right lung, the pulmonary artery is anterior to the bronchus, and in the left lung, the pulmonary artery is superior to the bronchus, right? Right anterior and left superior. So on the right side, the pulmonary artery, that is this pulmonary artery, is anterior to the bronchus, and in the left side, pulmonary artery is superior to the bronchus. And right lung is more common site for inhaled foreign bodies, because right main stem bronchus is wider, more vertical, shorter than the left. And if you aspirate a peanut or any other foreign object, for that instance, while supine, it usually enters the superior segment of the right lower lobe. Right lower lobe and superior segment. Okay. So if these are your lungs in supine, right, so the object will fall somewhere over here. Okay, because the bronchi is directed towards that direction. So this is the superior segment of the right lower lobe. Okay, and while lying on the right side, it usually enters the right upper lobe. Okay, while lying on the right side, it usually enters the right upper lobe, and the I think it's the posterior segment of the right upper lobe, or that I don't remember that right now. And while upright, it usually enters the right lower lobe. Right. Here only things are given about the right lower lobe. Okay, but the posterior segments of the right upper lobe are also very significant, because in supine position, both of these areas are very vulnerable, right? The superior segment of the right upper lobe and the posterior segment of the right upper lobe and the superior segment of the right lower lobe. Okay, and posterior segment of right upper lobe. So this is the anterior view. This is the mid-clavicular line, and this is very simple, I guess. Okay, and at inspiration, another 2 intercostal spaces are occupied by the lungs, and in posterior view, it is still the 9th intercostal space. The lower border of the lungs is in the 9th intercostal space. And mostly the intrathoracic drainage is done at the 5th to 7th intercostal space at the mid axillary line. Okay. This is the CT image. This is the pulmonary artery. And this is the ascending aorta. This is the descending aorta. The ascending aorta is very anterior and descending aorta is very posterior. Okay. And the pulmonary artery is in anterior of the descending aorta. Right. And this is superior vena cava. This is carina. Right. So where the division of the right and left bronchus takes place. Okay. So structures perforating diaphragm are at T8, that is there is IVC and right phrenic nerve. At T10 there is vagus and esophagus. At T12 there is aorta and thoracic duct. AT12. Okay, so at 12 I ate 10 eggs at 12, or any mnemonic that you can remember. So I ate, that is IVCI and T of 8, T8, IVC T8, 10 eggs, so that is T10 eggs, that is esophagus and vagus, and at 12. A is aorta and T is thoracic duct at 12, so that is T12. Diaphragm innervated by C3 to C5 phrenic. So pain from diaphragm irritation can be referred to shoulder C5 and trapezius ridge C3, C4. And phrenic nerve injury causes elevation of the ipsilateral hemidiaphragm on X-ray. Yeah, and C3, C4, C5 keeps the diaphragm alive. And other common bifurcations are common carotid bifurcates at C4, trachea bifurcates at T4, and abdominal aorta bifurcates at L4. Right. Yeah, the IVC and the esophagus both pierce the diaphragm through the central tendon, and the aorta pierce the diaphragm below the central tendon and under the median arcuate ligament. Right. Now the most boring part, the physiology of respiratory system. I know it might not be boring for some of you, but it's definitely very boring for me. And so the lung volumes and capacities. A capacity is a sum of more than two physiological volumes. So there are 4 volumes and 4 capacities. So tidal volume is very simple. We know that air that moves into the lung with each quiet inspiration without any forcing, that is 6 to 8 ml per kg, typically 500 ml. And inspiratory reserve volume is the air that still can be breathed in after a normal inspiration, so that is forceful inspiration. Expiratory reserve volume is air that can still be breathed out after normal expiration. Okay, that is forced expiration. So reserve volumes is the reserved volume is the volume that is reserved for forceful respiration. Right? Residual volume is the air in lungs after maximal expiration. RV and any lung capacity that includes RV cannot be measured by spirometry. Right. Now the inspiratory capacity is IRV plus sweet tidal volume. So air that can be breathed in after a normal exhalation. So maximum amount of inspiration that one can do, right? Not just after a normal inspiration, but the total normal inspiration plus forceful inspiration that makes up inspiratory capacity. Then there's functional residual capacity. It's just like residual volume, but it is a functional residual capacity. So we know that residual volume is air in lungs after maximal expiration. So residual volume is the air that is always present in the lungs, but we don't do maximal expiration every time, right? Every time we exhale out, it is not a maximal expiration. So that is why we have a functional residual capacity. So the volume of air that is present in the lungs just after a normal expiration. So that is very functional, right? Day to day like day to day life, from a normal, in a normal respiration, after a normal expiration, the volume of air that is in the lungs is called FRC. Volume of gas in lungs after normal expiration, outward pulling force of chest wall is balanced with inward collapsing force of lung, right? So at FRC, these pressure are equivalent to each other. The inward pulling of chest and the outward pulling of the inward pulling of lungs and the outward pulling of chest wall is balanced. Now the vital capacity, that is IRV plus ERV plus tidal volume. So there is maximum volume of gas that can be expired after maximal inspiration. So that maximum amount of air that can be breathed, that can be moved out of the lungs. Right? And the TLC, that is volume of gas present in lungs after a maximum inspiration. There is another thing, that vital capacity is increased in COPD. Why? Because we'll see later on that COPD is an obstructive lung disease. So there is problem with expiration only, not with inspiration, right? That is how we remember it. When there is problem with expiration, there is going to be also a problem with inspiration. But just for answering the question's sake, COPD is an expiratory problem, right? So any capacity that defines any expiratory volume of that defines an expiratory volume is going to be affected by the COPD. So in COPD, the vital capacity increases. No, sorry, the vital capacity is going to decrease, right? Because that is maximum volume of gas that can be expired after maximal inspiration, and the residual volume is going to increase. Now the work of breathing. Right. So the work of breathing, it refers to the energy expended or O2 consumed by respiratory muscles to produce the ventilation needed to meet the body's metabolic demand. It comprises the work needed to overcome both elastic recoil, first the elastic recoil, and second the airway resistance. So any work is equal to force into diameter is equal to pressure into volume. So minimized by optimizing respiratory rate and vital capacity. So it is increased in restrictive disease and obstructive disease, but through different methods. We'll see how. So in restrictive disease, the work of breathing is increased to overcome the elastic recoil achieved by increased respiratory volume and decreased vital capacity. Right. So in restrictive disease, the respiratory rate increase and the vital capacity, the tidal volume, Vt is tidal volume, that is being decreased. So the air that moves into the lung with each quiet inspiration is being decreased, right? Because as we know, the restrictive diseases are an inspiratory problem, and so there is going to be problem with inspiration, that is vital tidal volume, and there is going to be increased respiratory rate. So the restrictive disease patients have small quick respirations, and obstructive disease increased work to overcome airway resistance achieved with decreased respiratory rate and increased tidal volume. So as we know, there is long pursed lip breathing, right? So there is long pursed lip breathing in COPD patients. Now the determination of physiological dead space. So dead space is tidal volume into PaCO2 minus PeCO2 divided by PaCO2. PaCO2 is the arterial, the small a is always arterial PCO2, and PeCO2 is expired air PCO2, the pressure of carbon dioxide in the expired air, right? So Vd is the physiological dead space, and mostly physiological dead space is equal to the anatomical dead space of conducting airways plus alveolar dead space. We'll talk about that in a minute, what these spaces are. And the apex of healthy lung is largest contributor of alveolar dead space, right? And physiological dead space is equal to volume of inspired air that does not take part in the gas exchange. So what is Vd? Vd is the volume of inspired air that does not take part in gas exchange. Why doesn't it take part in the gas exchange? Because there isn't enough perfusion, right, to perform the gas exchange. Like for the gas exchange to happen, we need ventilation as well as perfusion. So there is enough ventilation in the apex of the lungs, right? If these are the lungs here, there is always enough ventilation because air comes from the above, and there is less perfusion in this area. So this is going to be physiological dead space. And physiological dead space increases in cases of pulmonary edema, in pulmonary embolism and all that. All those conditions where perfusion is affected, there is going to be increase in physiological dead space. And physio dead space is approximately equivalent to anatomical dead space in normal lungs, right? It may be greater than anatomical dead space in lung disease with ventilation perfusion mismatch, right? Because in normal people, in normal lungs, uh, in normal lungs there isn't any alveolar dead space, right? Because in normal healthy lungs, all alveoli are functioning normally, so there isn't going to be any alveolar dead space. So anatomical dead space becomes equal to that of physiological dead space, right? So here plus alveolar dead space, this becomes 0. So physiological dead space gets equal to anatomical dead space. And anatomical dead space is something where ventilation isn't happening. So it might be the base of the lung area where there is less ventilation and more perfusion, right? So now the minute ventilation, it is abbreviated as VE, total volume of gas entering the lungs per minute. So with each breath there is a tidal volume entering the lungs, and that times the respiratory rate gives us the minute ventilation. Right, and alveolar ventilation is the volume of gas that actually reaches the alveoli each minute. Minute ventilation is volume of gas entering the lungs, but alveolar ventilation is the volume of gas that reaches the alveoli each minute. Right. So the normal values of respiratory rate is 12 to 20, tidal volume is 500, and this physiological dead space is 150 ml per breath. Now the lungs and the chest wall, because of historical reasons and small pressures, pulmonary pressures are always presented in centimeter water, right? First is the elastic recoil. It is the tendency for lungs to collapse inwards and chest wall to spring outwards. At functional residual capacity, these both pressures are equal, right? We talked about this. So the airway and alveolar pressures equal atmospheric pressure. That is called zero. And intrapleural pressure is negative, preventing the atelectasis. The inward pull of the lung is balanced by the outward pull of the chest wall, and system pressure is atmospheric. Pulmonary vascular resistance is at minimum. So at FRC, all these things are happening, that the airway and alveolar pressures become equal, the intrapleural pressure becomes negative, and the system pressure is also atmospheric, and the pulmonary vascular resistance is at the minimum. Right. Now the tendency for lungs to collapse inward and chest wall to spring outwards are equal. So if this is the lung and this is the chest wall, the lung always has the tendency to collapse and the chest wall has the tendency to pull outwards. So these pressures get equal. And the compliance of a lung is change in lung volume for a change in pressure, how well it can fill the air, right? That is inversely proportional to wall stiffness and increased by surfactant, right? Because if the surfactant is increased, it is going to prevent the lungs from collapsing, right? So it is going to be kept open for a longer while, which will help them to fill more air, right? And it is inversely proportional to wall stiffness. If the wall stiffness is less, it is going to be easier to fill the lungs with the air, right? And increased compliance, the lungs are easier to fill. Example, emphysema and older adults. So increased compliance is not always a very good thing, because if you are very easily filling up the lungs, there is going to be problem expiring that air out, right? The lungs are going to be keep filling with more and more air, right? They are going to be hyperinflated like in emphysema, and so there's going to be a problem with expiration if the compliance increases too much. And the decreased compliance is lung more difficult to fill, that is with pulmonary fibrosis, that is restrictive lung disease, then pneumonia, ARDS, and pulmonary edema. Why pneumonia, ARDS, and pulmonary edema? Because there is fluid in the alveoli, right? If this is the alveoli, in pneumonia there is exudate and everything, right? There is consolidation in the alveoli. In ARDS and pulmonary edema, there is fluid in the alveoli, so it is going to be very difficult to push air into the alveoli, hence the less compliance. And also the fluid in the alveoli in ARDS and pulmonary edema makes the lung very heavy, and the walls of the lungs becomes more stiff. Right. What is hysteresis? It is lung inflation follows a different pressure volume curve. Lung inflation follows a different pressure volume curve than lung deflation due to need to overcome surface tension forces in inflation. Okay. Now let's see this graph here. So this green line is suggesting the compliance of the lung chest wall system, right? And as you can see, the emphysema is the blue line above the green line. So it has increased compliance, and the fibrosis is the red line. Below the green line, below the compliance is green line, so it has less compliance, right? And FRC also increases. FRC increases in emphysema and it decreases in fibrosis, right? Why does FRC increase in emphysema? Because as we talked about, it is an obstructive type of disease. It is a expiratory problem. So if there's going to be problem with expiration, there is going to be more residual volume and more functional residual capacity as well, right? And also, yeah, I want to talk about this ARDS thing that we did. It was a question in Uworld, like about the PEEP, positive expiratory and expiratory pressure, right? Positive and expiratory pressure. So what is PEEP? That in the patients of ARDS and pulmonary edema, we keep them on this PEEP to prevent the alveoli from collapsing, right? So how does it work? So this when the patient is kept on this PEEP, it makes a closed circuit to pressurize the inhaled air to diffuse through the alveoli, right? Because as we know, in a simple ventilation, we just provide inspiratory volume, right? But and the alveoli are we let the alveoli exhale themselves, right? But in pulmonary edema, we have a problem with pushing the air inside the alveoli, right? So what we do is we make a closed circuit, right? If this is the alveoli and this is connected, this is just a demonstration. If this is connected with PEEP, we are going to push air at inspiration, but we are also going to push air during expiration as well, like during inspiration as well as expiration. So what it will do is it is going to make a closed circuit of air. It is going to make a closed circuit of air. So if there is a closed circuit of air, there is going to be more pressure generated from the air that we gave, right? And if there is going to be more air pressure, it is going to be easier to fill the alveoli, right? And it is going to prevent the alveoli from collapsing. So let's just write down. It makes a closed circuit to pressurize the inhaled air to diffuse through alveoli. Yeah, and also if we are increasing the pressure of the oxygen in the alveoli, it is going to be easier. It is going to be easier for the oxygen to diffuse through the walls of the alveoli. And it's about making a closed circuit in pulmonary edema rather than giving the 100% oxygen. So that is very high, that 100% supplemental O2 will not do a thing. Will not do a thing in pulmonary edema. Only PEEP is going to work, right? Now the pulmonary circulation. So pulmonary circulation is normally a low resistance and high compliance system. So it becomes easier to fill the pulmonary circulation, right? A decrease in PaO2 causes hypoxic vasoconstriction. that shifts blood away from poorly ventilated regions of the lung to well ventilated regions of the lung. Right, PaO2 is the alveolar oxygen pressure. If the if the FiO2 is low, for instance, the oxygen pressure in the inhaled air is low, there is going to be less PaO2, less alveolar oxygen, and that is going to cause hypoxic vasoconstriction. So hypoxic vasoconstriction is a very important topic for question stems, right? So what happens in a hypoxic vasoconstriction? If these are the alveoli, one of them is getting low O2 and one of them is getting high O2. So and these are the pulmonary capillaries. Right, so if this alveoli, the first alveoli is getting less O2, there is going to be hypoxic vasoconstriction. So what happens is the pulmonary capillaries surrounding those alveoli are going to constrict, right? So it is automatically decreasing the perfusion of those hypoventilated alveoli, so that the blood can be reserved for the alveoli that are well ventilated, right? Now the perfusion pressure, perfusion limited O2, that is in normal health, and O2, CO2 and N2O. All these three gases are perfusion limited. So gas equilibrates early along the length of the capillary, and exchange can be increased only if the blood flow is increased, right? Right, so what does this mean? That the O2, CO2 and N2O is perfusion limited, and this is going to take some time. So normally what happens is the diffusion of oxygen is so rapid that it depends on the perfusion of the alveoli, that how well the oxygen is going to get diffused along the wall of the alveoli, right? So if this is the alveoli, right, so the diffusion of oxygen is so rapid that if the oxygen is traveling in this direction, so almost at the one third of the capillary length, the oxygen is going to get diffused into the capillaries, right? So the diffusion of oxygen is so rapid that the red blood cells become fully saturated with oxygen at only one third of the total alveolar capillary length. So it depends only on the perfusion of the alveoli, right? So normal oxygen transfer is perfusion limited. That is, the diffusion is so fast that the oxygen transfer depends on the perfusion rate only, right? And the perfusion rate is dependent on the cardiac output. So during exercise, when the cardiac output is increased, there is going to be increased diffusion of oxygen, right? Understood? So oxygen diffusion is so fast that the oxygen transfer depends only on the perfusion of the alveoli. If you start solving questions, it will get more clear and clear, right? And it can also become diffusion limited. Like the diffusion wasn't the problem in normal humans. There is always going to be enough diffusion of oxygen, but there can be difference in the perfusion. Like there is going to be difference in the cardiac output when we are resting and when we are exercising. There is going to be difference of cardiac output. So likewise, there is going to be also changes in the perfusion of the alveoli, right? So in normal humans, it is perfusion limited. But in patients of emphysema and fibrosis or any diseases which affects the diffusion of the oxygen from the alveoli into the capillaries, be it any uh, like fibrosis where the space between the alveoli and the capillaries is being fibrosed, or in emphysema where there is less surface area for the transfer of oxygen, the transfer becomes diffusion limited, right? So there is air. Why is it called diffusion limited? Because in emphysema, let's first just talk about fibrosis. The wall of the alveoli are being fibrosed, so it is not going to let O2 pass that easily. So but the perfusion is always normal, like it is getting enough blood in its surrounding capillaries, but because the wall of the alveoli are fibrosed, it is not going to let the oxygen transfer easily through the walls of the alveoli, right? And in emphysema, uh, like in emphysema, the alveoli are hyperinflated, right? But the alveoli are hyperinflated, but the effective surface area for the transfer of oxygens is being decreased. See, this is the, if we consider this area to be the area for the transfer of the oxygen, there is also this area that is being wasted because the alveoli are now hyperinflated and oxygen is going to go to all of these areas. So oxygen in this area is going to go to waste because it cannot transfer through the wall of the alveoli, right? So that is also again diffusion limited, right? And also carbon dioxide is diffusion limited. So gas does not equilibrate by the time blood reaches the end of the capillaries. So what we talked about in perfusion limited, that even at the 1/3 of the length of the capillaries, whole of the oxygen is getting transferred. So it was just perfusion limited. But what happens in diffusion limited, emphysema and fibrosis, even if the oxygen is traveling throughout the length of the capillaries and alveoli, it is not going to get transferred because it is diffusion limited, right? And also there's one more thing, that oxygen diffuses very slowly, right, while CO2 diffuses very rapidly across the alveolar membranes. So disease states that lead to diffusion limitation like pulmonary fibrosis are more likely to cause early hypoxia than hypercapnia, right? Because CO2 can cross the barriers very easily. Oxygen can cross the barrier very easily and get exhaled out of the system, but at the same time O2 cannot enter the circulation very easily, right? So there is going to be hypoxia, but there isn't going to be hypercapnia, right? Because the CO2 is still able to exhale out of the system. Also, there's just one more thing that I would like to add here. There was a concept that uh, why in interstitial lung disease, in fibrosis and all, there is exertional dyspnea, right? So if this is the alveoli, and we are just simplifying it, like if this is the pulmonary capillaries, and so during exercise there is going to be increased cardiac output, right? Be it in a normal humans or in patients of ILD, there is going to be increased cardiac output and there is going to be increased in pulmonary blood flow. But there's also increase in the heart rate, right? So there is going to be less time for the pulmonary blood to stay here at the alveoli. In other words, there is going to be increased transit time. Like the pulmonary blood flow is going to be increased, but it is going to come fast and it is also going to go away fast, right? And there, as we know, the walls of the alveoli are now fibrosed. There is going to be difficult oxygen diffusions through that fibrosed wall, and also in addition to that, if the transit time of the pulmonary blood flow has also increased, it is not going to stay there for a longer period, which is going to make the diffusion of oxygen more difficult, right? So that is going to cause dyspnea while exercising, right? So yeah, it's just that during exercise, the increase in the pulmonary blood flow accelerates the transit through the pulmonary capillaries, reducing the time for oxygen extraction, right? So pulmonary blood flow is the transit time of pulmonary blood flow is increasing, so there isn't going to be much time for it to extract the oxygen out of the alveoli, in addition to being the difficult diffusion in the fibrosed alveolar wall, right? So in patients with diffusion limitation, the increased blood flow during exercise can result in exertional hypoxemia, right? Even if the oxygen is normal at rest, the patient is not going to feel anything while being at normal, but when it starts exercising, it undergoes hypoxemia, right? Now the chronic hypoxic vasoconstriction may lead to pulmonary hypertension, plus or minus cor pulmonale, right? So whenever there is vasoconstriction for a prolonged period of time, it is going to cause hypertension. Now if that vasoconstriction is in the pulmonary system, it is going to cause pulmonary hypertension, and so that is why all this COPD and everything, it leads to pulmonary hypertension and eventually cor pulmonale, because there is always hypoxia in COPD and all lung disease. So that hypoxia is going to cause hypoxic vasoconstriction, as we saw here, and that is going to cause pulmonary hypertension and cor pulmonale. So diffusion is A into D K into P1 minus P2 divided by delta X, where you don't have to remember this formula, but you just have to understand this formula, that diffusion depends on the surface area of the alveoli, the oxygen content, that is PaO2 minus the O2 content in the alveoli, that is P small o2, and the wall thickness, right? So yeah, diffusion depends on the area. It is directly proportional to the surface area. If the surface area of the for the transfer of oxygen is high, there is going to be more diffusion. The alveolar thickness, it is inversely proportional to the alveolar thickness. So if the thickness of the alveoli is increased, like in fibrosis, pulmonary fibrosis, there is going to be difficult diffusion, right? P1 minus P2 is the difference in partial pressures, that is PaO2 minus PaO2. The difference in the arterial O2 minus the alveolar O2. So if that difference is high, there is going to be more diffusion, right? Because if that difference is high, which means that there is going to be increased O2 in alveoli and decreased O2 in artery. So that is what diffusion is basically, right? So the transfer of gas from higher pressure system to lower pressure. So the diffusion will get easier from alveoli to the artery, right? And surface area decreases in emphysema, even though there is hyperinflation of emphysema, like right here we talked about. This is the hyperinflated alveoli. Even if the alveoli are hyperinflated, the area of the area which is used for the transfer of oxygen is also going to be wasted, right? This space right here, which is of no use for the oxygen transfer, that space is also going to increase. So that is going to cause less efficient oxygen transfer, right? So the effective area for transfer in emphysema decreases, right? And delta X increases in pulmonary fibrosis. What is delta X? Yes, the alveolar wall thickness, as we talked about, increases in pulmonary fibrosis. Now, the DLCO is the extent to which carbon monoxide passes from the air sacs of the lung into the blood. Extent to which carbon monoxide passes from air sacs of the lung into the blood. There was something I want to talk about in DLCO. Like if I think it's not given in the first aid, it's given in medicine, but it's an important or rather interesting thing to talk about. That yeah, so let's discuss what DLCO is and how it varies among the different diseases. So DLCO is the diffusion of the carbon monoxide, right? Why is it carbon monoxide? Because we use carbon monoxide as the gas for this test, right? So in most of the disease, be it obstructive or restrictive, there is going to be decrease in DLCO, right? But let's first of all discuss asthma. In asthma, there is going to be increased in DLCO. Why? Because in asthma there is hypersecretion, right? And it's a kind of reaction, right? So it's an autoimmune, so it's an inflammatory reaction, right? So during inflammation there is rubor, so there is increased in pulmonary capillaries, blood supply, right? There is increased blood supply. So the first thing happening is air trapping. Because of all the secretions in the bronchi and the alveolar system, there is going to be air trapping in the alveoli, which is going to increase the diffusion across the alveolar membrane. And second is there is increase in capillaries. So if there is increase in capillaries, there is increased perfusion, right? So if there is increased in perfusion, there is going to be increased in the diffusion of the carbon monoxide, right? In all other diseases like COPD, all the COPDs, ILD, like fibrosis, emphysema, ARDS, pulmonary edema, the DLCO is going to decrease, right? So this was the the DLCO is going to decrease. Only in asthma the DLCO is going to increase, and also in chronic bronchitis the DLCO is somewhat normal, because it's in the name, right? The chronic bronchitis, it's a disease of bronchi, so none of the alveolar walls or capillaries are going to get affected. There is a disease somewhere over here in the bronchi, right? So it's not going to affect any kind of diffusion of any kind of gas, right? Okay. Now the pulmonary vascular resistance. So PVR is pressure of pulmonary artery minus pulmonary pressure of left atrium, right? So remember that difference in pressure is equal to Q into R. So Q is the cardiac output and R is the resistance And yeah, you just have to understand this formula, that the resistance is inversely proportional to the radius. So if radius of the vessel is increased, there is going to be less resistance into the power of 4. And pressure of the left atrium is also called the pulmonary capillary wedge pressure, that is of pulmonary vein, right? And the resistance is also directly proportional to the viscosity of the blood and the length of the vessel, right? And inversely proportional to the radius of the vessel. If the radius is broad enough, there's obviously going to be less resistance, right? Also, we forgot about this graph here. So this is the point of equilibration here, right? That the alveolar O2 reaches the pressure of the arterial O2, right? So this is, and here the alveolar carbon dioxide pressure reaches the arterial the alveolar pressure of carbon dioxide reaches that of the arterial carbon dioxide. So that is just equilibration, that the alveolar and arterial pressures gets equal, right? Right, and this is the length along the pulmonary capillary. So as we talked about, that oxygen is perfusion limited, right? And it gets the gas equilibrates early along the length of the capillary, that is almost at the 1/3 of the length of the pulmonary capillary. So as you can see, this is the length of the capillary. Like at the 1/3 of the length of the pulmonary capillary, oxygen is being diffused easily. And when it is diffusion limited, that is in case of fibrosis or emphysema, that is it is going to take up the whole length of pulmonary capillary to diffuse itself across the alveoli. So as you can see, there is no literal equilibration right here for the diffusion limited oxygen transfer. Yeah, there's not much in that graph. Now the VP mismatch. So ideally ventilation is matched with perfusion per minute, that is VQ ratio should be 1, but that is ideally for adequate gas exchange. So VQ at apex of the lung is 3, so that is wasted ventilation. So there is so much of air in the apex of the lung because it is closer to the nose, right? So there is going to be more air in the apex of the lung, but there isn't enough perfusion, right, to make that transfer. So the V is very high and the Q is slightly less, so that is going to cause VQ to be very high, that is 3, and VQ at the base of the lung is 0.6 wasted perfusion. So why it is called wasted ventilation? Because there is so much of air in the lungs that it gets wasted because there isn't enough perfusion, right? And at the base of the lung there is wasted perfusion, like there's so much of the blood coming in from the heart, but the air coming in from the nose isn't able to reach the base of the lung because it is further away from the nose, right? So V is normal, the Q is high, so VQ is going to be less, that is 0.6, and it is wasted perfusion. So there is so much of blood coming into the lungs at the base of the lungs, but there isn't enough ventilation to make the transfer happen. So there it is called wasted perfusion, right? So both ventilation and perfusion are greater at the base of the lung than at the apex of the lung. Okay. So generally ventilation and perfusion are called to be greater at the base of the lung than at the apex of the lung. And with exercise, there is increase in cardiac output. So there is vasodilation of apical capillaries, as we talked about, that ventilation is higher in the apex of the lung, but there isn't enough perfusion. But with exercises there and with increase in cardiac output, there is going to be vasodilation of the capillaries of the apex of the lungs too. And so the VQ ratio approaches 1. So the VQ starts increasing slowly and the VQ ratio reaches 1. In certain organisms that thrive in high O2, that is tuberculosis, flourish in the apex. Right? And this is the one way I remember that the heart is over here. Right? So the air is coming in from the nose, so obviously it is going to be more at the apex of the lung, because the apex of the lung is closer to the nose, and it is difficult for air to reach the base of the lung because it is further away. But on the other hand, the heart is closer to the base of the lung, right? So the perfusion is going to be higher at the base of the lung, and it is difficult for the blood to reach the apex of the lung, right? So V is more here and Q is more here. Now when is this VQ ratio is 0? When the ventilation is 0, right? Because if the Q is 0, it is going to be infinite. So when V is 0, VQ ratio becomes automatically 0. So when is V 0? When the person is dead, right? So there is no ventilation, so the VQ ratio is going to be 0. Or when the person is alive, we care for the person who is alive right now. When his VQ is going to be 0? When V is 0, there is airway obstruction, so there is no air reaching lungs at all, right? So in shunt, 100% O2 does not improve PaO2 because there is a foreign body lodged. It will not let any kind of air, either it is 10% oxygen or it is 100% oxygen. It is not going to let that oxygen reach the lungs at all, right? So 100% O2 will not improve PaO2. PaO2 is the alveolar air, right? And when is VQ infinite? When the perfusion is 0. So blood flow obstruction, physiological dead space, right? So it is called physiological dead space, when there is no perfusion at all, but there is normal ventilation. That is physiologic. Physiologic is related to blood, anatomic is related to the alveolar space, right? Anything wrong with the alveolar space will affect the anatomical dead space, and anything related to the perfusion, anything related to the pulmonary capillaries and the blood flow, that is going to affect the physiological dead space, right? And assuming less than 100% dead space, 100% O2 improves PaO2, like in pulmonary embolus, right? So let's understand that. So this is the pulmonary capillaries, just making this kind of diagram for simplifying. Like it is very rare that the pulmonary embolism will be here, and it is just impossible, not even rare, but impossible for the pulmonary embolus to be here and obstruct the whole of the pulmonary circulation to the whole of the lung. It will not be possible that the pulmonary blood flow will be obstructed for whole of the right lung, right? The pulmonary embolism will be going to be somewhere over here, so it is only going to affect the segment of the lung, right? And this is the bronchi coming in. This is the bronchi. This is ventilation, and this is perfusion. So even though there is pulmonary embolism here and there is Q is 0, but the perfusion in other normal pulmonary capillaries is going to be somewhat more than 0 or even normal, right? So whenever there is we give 100% oxygen, we are going to increase ventilation here, here and here, right? So if the Q is normal in the first two capillaries and we increase the ventilation, there is obviously going to be improvement in the condition of the patient. It's just that this part which is being affected by the pulmonary embolisms, perfusion, zero perfusion, the ventilation is not going to cause a thing, right? So assuming that the less than 100% dead space, so this is less than 100% dead space, right? Because these two are normal, so 100% oxygen improves PaO2, right? So this is just what we talked about. Okay. There's one more thing, in which conditions ventilation is affected and in which conditions perfusion is affected. So let's first talk about the ventilation. So ventilation is decreased in first ARDS, right? Because there's fluid in the alveoli, it is not going to let the oxygen pass through the alveoli. And second is pulmonary edema, same, there is fluid accumulation. Also there is pneumonia, but the ventilation will be somewhat preserved in pneumonia. It will not be as severe in ARDS and pulmonary edema, right? Because we know the patients of ARDS and pulmonary edema are more fatal than the pneumonia, right? And the fourth is atelectasis. So for the first two condition, ventilation is going to be very, very low, and for the last two condition, ventilation is going to be somewhat low. And for perfusion, decrease in perfusion, there is our pulmonary embolism, right? So there is going to be little decrease in perfusion with the pulmonary embolism because it is a segmental embolism, right? It is not going to affect all of the pulmonary capillaries. But if it is a massive pulmonary embolism, it can affect or it can also compress the other pulmonary capillaries, right? So that is going to decrease the perfusion by a higher rate. And also the pulmonary artery hypertension, because there is vasoconstriction of the pulmonary arteries, it is going to affect all of the pulmonary arteries and it is going to decrease the perfusion throughout the lung, right? And also we have to discuss what a shunt is, right? So whenever there is ventilation is 0 because of obstruction, the blood coming in from the heart, the blood coming in from the right heart goes back unoxidized to the left heart, right? Because the ventilation is 0, the transfer of O2 and CO2 is not taking place. So the blood that came from the right heart will go back to the left heart unchanged, right? So that is what a shunt is, right? So we in pediatrics we have seen the right to left shunts, that is right to left shunts. So this is also right to left shunt, right? So blood coming in from the right heart, that is pulmonary arteries, will go back unoxidized because the ventilation is 0, through pulmonary veins. So it is kind of a right to left shunt, like ASD. No, not like ASD, just right to left shunt. We'll keep it that way. So the alveolar gas equation, so that is PaO2, that is alveolar O2 is equal to PiO2, that is oxygen pressure in the inspired air, right? So that is inspired air oxygen pressure minus PaCO2 divided by respiratory quotient, and it is normally 150 mmHg, that is at the sea level breathing room air, and the respiratory quotient is 0.8. See, the formula itself is not very important, but this gradient that we will talk about, that is PaO2 minus PO2, the difference in the pressure of the air between the alveoli and the arterial system, that gradient is very important in the questions of hypoxia. Like there will be so many questions of hypoxia where we have to differentiate which kind of hypoxia or the reason behind the hypoxia, so that we can do by knowing the AA gradient. So first, let's see what the normal AA gradient is. The normal AA gradient estimated as age 4 is +4, and for a person less than 40 years old, the gradient should be less than 14. So as the age increases, the gradient also increases, right? And yeah, so as I said, there will be questions about questions where you have to differentiate what kind of hypoxia is it. So if the AA gradient has increased and you give 100% of oxygen, the question stem itself will give you that 100% of supplement O2 was given, and the patient's condition improved. So if we give 100% oxygen and the patient improves, it just might be that the diffusion of the oxygen was not normal. So the diffusion of the oxygen across the alveolar membrane was not happening normally, and when we gave 100% O2, that issue was resolved. So what all conditions can it be? It can be either ILD or emphysema or fibrosis or even pneumonia. All those conditions where diffusion of oxygen was not taking place normally across the alveolar membrane. And what if giving 100% of oxygen does not improve, right? Does not improve the condition? Then it is a case of pulmonary edema, where there is a need of PEEP. As we talked about, PEP forms a closed circuit, so oxygen can be pushed more with more strength across the alveolar membranes, right? So these all conditions are if the AA gradient is higher, right? But if the AA gradient is normal, like let's talk about that, there can be hypoxia, but there still can be normal AA gradient, right? So if the normal gradient is there and the patient is still hypoxic, the issue can be in the patient, or the issue can be in the inspired air itself. If the inspired air itself has low FiO2, that is this PiO2, the oxygen pressure in the inspired air is itself low, there is going to be less oxygen in the alveoli, right? So which are the cases where there is less FiO2? The first is altitude and asphyxia. The oxygen is not reaching the alveoli completely, right? So there is going to be low FiO2, and the PCO2 will be normal. We'll talk about it in a minute, why I mentioned PCO2 here, PaCO2 here, right? And the second reason is, if there is a normal gradient and the patient is hypoxic, so the first thing we talked about, the issue can be in the inspired air, or the issue can be in the patient, but it might not be related to the respiratory system, right? The patient can just be hypoventilating because of some external factors that are not related to the respiratory systems. So first is obesity hypoventilation syndrome, right? So patient is hypoventilating, so that is why oxygen is not reaching the alveoli properly. So the second is opioids, so it suppresses the respiratory centers in the brain, right? And third is neuromuscular disorders, right? So the muscles of the respiratory systems are not working properly, so that will lead to hypoventilation with normal A gradient. But in all these three conditions, the PaCO2 is going to be higher. So that is how we differentiate between disorders with normal AA gradient, right? So first of all, if the patient has hypoxia, if the patient has hypoxia, we look at the AA gradient. If the AA gradient is on the higher side, then we go about giving supplemental O2. And if the supplemental O2 is improving the patient's condition, it might be emphysema, ILD, pneumonia, or any other thing. And if the 100% O2 can't improve the patient's condition, it can be pulmonary edema. This is all if the AA gradient is on the higher side. But now if the gradient is normal, we then look at the PaCO2. If the PaCO2 is higher, it can be any other cause making the patient hypoventilate, that is OHS, opioids, or neuromuscular disorders. So if the patient is hypoventilating, it is expiring low too, right? It is not only inspiring less, but it is also expiring less. So the PaCO2 is going to increase in the body. And if it is due to an altitude problem or asphyxia, there's issue in the inspired air, right? The oxygen pressure in the inspired air is less, so that is not going to do anything with patient's expiration, right? Patient can still expirate the CO2, right? So PaCO2 will be normal in all those cases. This is a little bit confusing to understand at first, but there is a flow chart somewhere in Uworld, right, which makes this all very easy to understand, right? Right. So now carbon dioxide transport. So CO2 is transported from tissues to lung in three forms, right? CO2 is transported from tissues to lungs in three forms. So the first is in the bicarbonate form, that is 70% of the all transport occurring. So 70% of the carbon dioxide is transported through the bicarbonate route, and bicarbonate chloride transporter on RBC membrane allows the bicarbonate to diffuse out of plasma and chloride to diffuse into the RBC. That is called chloride shift. Here it is. So the bicarbonate is going out of this RBC and chloride is going into the RBC via facilitated diffusion countertransport. And second route is the carboaminohemoglobin or HbCO2, that is 21 to 25%, and CO2 bound to hemoglobin at end terminus of globin but not heme. So like O2, it is not bound to heme, but CO2 is bound to globin's end terminal, right? And CO2 favors deoxygenated form, right? So O2 is unloaded. Right. So if no, we'll discuss that later on. So the third part is the dissolved carbon dioxide, which is just 5 to 9%. In lungs, oxygenation of hemoglobin promotes dissociation of H plus from hemoglobin. Right. This shifts equilibrium towards carbon dioxide formation. Therefore, carbon dioxide is released from RBCs. Majority of blood CO2 is carried as bicarbonate in their plasma form. So whenever oxygen binds to hemoglobin, the already bound H plus from hemoglobin gets released into the blood. Okay. Right, so let's see the diagram. See, this is the tissue capillary wall, and CO2 is entering the RBC, and two of the three parts use RBCs to transport the carbon dioxide. So the first part is CO2 enters the RBC and is converted to bicarbonate through carbonic anhydrase, right? So CO2 plus H2O gives H2CO3, and then it gives H plus bicarbonate, right? So this is the carbon dioxide, and through RBC the bicarbonate gets released into the through bicarbonate the carbon dioxide is being transported throughout the body, right? So whenever it is needed, the bicarbonate will leave the RBC, and in exchange chloride will enter the RBC. That is called held in that is called chloride shift, right? That is called chloride shift. Held in shift is the CO2 released from the RBCs. Okay. Now the H plus that is formed from the H2CO3 will bind to HB, and it will form HHB, right? Hemoglobin bound to the hydrogen ion. The second path is carbon dioxide binds the hemoglobin, the end terminus of globin, and it will transfer in the form of HbCO2, right? And the third is dissolved carbon dioxide. Yeah, and the bicarbonate that is formed here, it is not shown here, that, but I would just like to add that the CO2 is being formed in the tissue, right? So from tissue it entered the RBC into the plasma, and that RBC will carry the carbon dioxide to the pulmonary capillaries, right? So this bicarb will go to the lungs, and in lungs there is going to be oxygen waiting to get inhaled, right? So there is HHB plus O2 in the lungs waiting to get inhaled, right? The oxygen is waiting to get inhaled. So what happens in lungs is the H plus diffuses out, the HB gets freed for the O2, So this is going to form HbO2, and the H plus ion that diffused out of HHB will bind to bicarbonate and will give rise to H2CO3, which will again diffuse to form H, not H plus but H2O plus CO2. And in this way, CO2 from the tissue got converted into bicarbonate, and bicarbonate again got converted into CO2 at the pulmonary capillary site. Now this CO2 will get exhaled, right? And we got the hemoglobin oxygen formation too right here. Right, and this was just about the bicarbonate form of transfer. Now let's see the second form, that is through hemoglobin, carbon dioxide binding hemoglobin. So as we know that hemoglobin is in the form of binding, it's in the form of HHB, that is hydrogen ion bound to hemoglobin. So whenever carbon dioxide wants to bind to hemoglobin, the H plus diffuses out and the hemoglobin binds to the CO2. So now whenever there is increased CO2, right, it is going to get bind to the hemoglobin, right, and the more hydrogen ion is going to get released into the bloodstream, which is going to cause acidosis. So that is why hypercapnia may lead to acidosis. And also there was a question stem. There is asked that it was indirectly asked that which blood has the most amount of chloride ions. So chloride ion is maximum in venous blood, right? Why? Because venous blood has the most amount of carbon dioxide, right? It is deoxygenated blood, and whenever there is more carbon dioxide, it is going to enter the more carbon dioxide is going to enter the RBC, more H2CO3 is going to be formed, more H plus ion is going to be formed, and if more bicarbonate ion is being formed, more exchange of chloride and bicarb will take place, and the chloride shift is going to increase and more chloride will enter the RBC, right? So there is more chloride ion in RBCs of venous blood. Okay, sorry, I wrote this sentence a little bit wrong. Chloride ion is maximum in RBCs of venous blood than RBCs of arterial blood. Not actually in venous blood, but the RBCs of venous blood. Now hypoxia and hypoxemia. So what is hypoxia? It is decreased O2 delivery to tissues, and hypoxemia is insufficient oxygenation of blood. So there is less O2 in the blood itself, that is called hypoxemia. And if there is enough, even if there is enough blood, enough O2 in the blood, if the oxygen delivery to the tissues is low, it is called hypoxia. Commonly due to decreased cardiac output, hypoxemia, there is not enough oxygen in the blood itself. Ischemia, there is anemia, there is not enough carrier, that is Hb. There's carbon monoxide cyanide poisoning, which binds to hemoglobin. And the mechanism of hypoxia is, we already discussed it here, how to differentiate hypoxia, but let's just see it again. That we can discuss the increased AA gradient first, because we did it the same way the last time we discussed it here, right? So let's just first discuss the increased AA gradient part. So when does the AA gradient increase? It can be diffusion limitation, that is fibrosis, right? It is at the alveolar level. The problem is at the alveolar level in increased AA gradient. So diffusion limitation can be there, that is fibrosis, which has a thick wall, so oxygen can't diffuse easily. There's VQ mismatch, normal perfusion in the areas of decreased ventilation, like at the base of the lung. Right. Why is there decreased ventilation? Because there can be consolidation, there can be fluid accumulation like in pulmonary edema, there can be consolidation like in pneumonia. So that all can lead to decreased ventilation but normal perfusion. And it is most common at the base of the lung. And the third is right to left shunt, normal perfusion in the areas of no ventilation at all. Right. It can be anatomic, that is intracardiac shunt, or physiologic, example perfusion of non-ventilated alveoli in ARDS. Right. Or it can be due to obstruction. Right. So we talked about the obstruction earlier, that whenever there is obstruction, there is foreign body or something like that, the ventilation is zero and the perfusion is normal. So the blood coming in from the right heart will go to the left heart without being oxidized, right? So because there is no diffusion. Okay. So that is called right to left shunt. There is normal perfusion in the areas of no ventilation. It can be anatomic, that is intracardiac shunt, that is right to left shunts in the heart because of the heart pathologies itself, or physiologic, that is perfusion of non-ventilated alveoli in ARDS. Right. Here we saw that in ARDS and pulmonary edema the ventilation is very low, right? So in those cases the shunt can be formed. Now the normal AA gradient. When can there be hypoxia with the AA gradient being normal? So we know that the problem is not at the alveolar level. The problem can be in the inspired air, or the problem can be with the patient not able to inspire air properly, right? So if the first issue we will talk about is the problem with the inspired air, right? So the inspired air does not have that much of oxygen pressure that it should have normally. So PiO2 is FiO2 into Pb minus PH2O, most commonly due to decreased Pb in high altitude. So you just have to remember that the FiO2 is decreased, right, with the altitude. High altitude has less air has low oxygen pressures, right? And second is hypoventilation. The patient itself is not able to inspire air like a normal person would, and the issue may or may not be related to the respiratory system. It may lead to substance abuse or neuromuscular problem or neurological problem like OHS and opioids and neuromuscular disorders like weakness and all, right? So it can be due to CNS depression, obesity, hyperventilation syndrome, and muscular weakness, right? Okay, so PEEP is needed if it's a pulmonary edema, right? AA gradient normal. Right, so PaCO2 will be normal here and PaCO2 will be on the higher side here, because there is problem with the whole breathing process, like inhalation plus exhalation. So if there is problem with exhalation, PaCO2 is going to rise, and here there is problem with the inspired air only, right? So there is nothing wrong with expiration or the expired air, so PaCO2 is going to be normal. Also, yeah, hypoxemia is insufficient oxygenation of blood, so PaO2 is less. And PaO2 may or may not be less in hypoxia, may be normal too, right? But in hypoxia, PaO2 is definitely low. That is the definition of hypoxemia. Right, so now let's discuss hemoglobin. We discussed CO2 transport, we discussed vacuum mismatch, gas exchange, we discussed hypoxia, normal pulmonary circulation. Oh. Why isn't it annotated? Oh. It gave me many heart attack. Where did all of my annotations go? Yeah, so hemoglobin. So normal adult hemoglobin is composed of 4 polypeptide subunits, that is 2 alpha and 2 beta, that each bind 1 O2 molecules. So one hemoglobin molecule can bind 4 O2 molecules. Hemoglobin is an allosteric protein that exhibits positive cooperativity when binding to O2, such that oxygen hemoglobin has high affinity for oxygen. Oxygenated hemoglobin has high affinity for oxygen, and deoxygenated hemoglobin has low affinity for oxygen. So the first time oxygen is binding to the hemoglobin, it is going to be difficult, but as it keeps binding more and more hemoglobin, it gets easier. Like it's just like USMLE journey. Like if you to begin with the USMLE journey is the toughest part, and to get to know about the whole process, to get to know about how to make connections, how to do networking, how to find USC. But once you are in the process, you find it a little bit easy. I would not say completely easy, but it's a little bit easier than before, right? So the protein component of hemoglobin acts as buffer for H plus ions. Myoglobin is composed of protein component of hemoglobin acts as buffer for H plus ion, so it is generally bound to hemoglobin. And myoglobin is composed of a single polypeptide chain with one heme moiety, and it has higher affinity for oxygen than hemoglobin. So myoglobin has just single polypeptide, whereas hemoglobin has 4 polypeptide and just higher affinity for oxygen. Right, the oxygen content of blood, O2 content is the O2 bound to hemoglobin plus O2 solubilized in plasma. So 1.34 into hemoglobin into saturation of hemoglobin plus 0.003 into PaO2 is very low yield, I would say. So O2 saturation is percentage saturation of arterial blood with oxygen. 0.003 is the solubility constant of O2, and PaO2 we know it's the partial pressure of O2 in arterial blood. So normally 1 gram hemoglobin can bind 1.34 ml oxygen, and normal hemoglobin amount in blood is 15 gram per deciliter. So the O2 binding carrying capacity is somewhat around 20 ml O2 per deciliter of blood. With decreased hemoglobin, there is decreased O2 content of arterial blood, but no change in the O2 saturation and PaO2. Right. Right, because O2 saturation is the saturation of oxygen in the arterial blood, not hemoglobin. Right. So even if the hemoglobin is low, like in the anemic states, we don't have low SaO2, right? You will never see a patient of anemia with low oxygen saturation. Right? So even if there is low hemoglobin, there is decreased O2 content of arterial blood, but no change in oxygen saturation and PaO2. Right? O2 delivery to tissues is cardiac output into O2 content of blood. And hemoglobin concentration, oxygen saturation, PaO2, total O2 content, like it's so carbon monoxide, there is normal hemoglobin concentration, decreased saturation of hemoglobin because the carbon monoxide competes with oxygen, so the oxygen saturation is going to decrease. PaO2 is going to be normal and total O2 content is going to decrease. Why total O2 content is going to decrease? Because the decreases the O2 bound to hemoglobin, and carbon monoxide decreases the or instead competes and replaces the oxygen in bound to the hemoglobin. So that is going to be a factor to decrease the total O2 content. In anemia, hemoglobin itself is low, so saturation is going to be normal, because as we talked about, the SaO2 or oxygen saturation is that of the arterial blood, not hemoglobin. Even if the hemoglobin is low, the oxygen saturation is going to be normal. PaO2 is going to be normal, but the total O2 content is going to be decreased because hemoglobin is decreasing, right? Polycythemia, the hemoglobin concentration is going to increase. O2 saturation has nothing being related to the hemoglobin concentration, so it is going to be normal. PaO2 is normal and total O2 content is going to increase. Methemoglobinemia, the Hb concentration is normal. Oxygen saturation is going to be decreased because Fe3, that is ferric ion, is poor at binding O2. Okay. Because the methemoglobinemia has Fe3 plus. PaO2 is normal and total O2 content obviously is decreased. Cyanide toxicity, hemoglobin concentration is normal, oxygen saturation is normal, PaO2 is normal, and total O2 content is normal. So what is the problem with cyanide toxicity? That we will see later on here. We'll see later on, right? Now the O2 dissociation curve. Shifts in oxygen hemoglobin dissociation curve reflects local tissue oxygen needs. It can be helpful, meets metabolic needs, or harmful in toxicities, pathophysiologic situations. Right. So the right shift in ODC reflects decreased hemoglobin affinity for oxygen. So increased O2 unloading at tissue will occur. So decreased hemoglobin affinity at the tissue level is beneficial for us because it helps increasing the O2 unloading at the tissue. Physiologically occurs with increased O2 needs, that is exercise, decreased pH, or we would say increased increased hydrogen ion, increased temperature, fever, and hypoxia, or increased 2,3 BPG. And at the cellular level, caused by increased H plus and increased CO2 created by tissue metabolism. That is Bohr effect. So we saw earlier that carbon dioxide helps in O2 unloading, right? Carbon dioxide favors deoxygenated form, so O2 is being unloaded. So carbon dioxide helps unloading the oxygen from the hemoglobin. So how we will remember this? So this is the right shift. Right? So how are we going to remember the right shift, causes of right shift? Everything that increases causes the shift to go to the right side. So hydrogen ion increase, 2,3 BPJ increase, temperature increase, and CO2 increased. Right. And left shift in ODC reflects increased hemoglobin affinity for oxygen, so that will lead to decreased O2 unloading at tissue, that is harmful for us. That physiologically occurs with decreased O2 needs, or it's not actually harmful for us, but it can be harmful. But sometimes there's a need to decrease the O2 unloading at tissues too, right? Because we don't need much oxygen at few conditions. So in those few conditions, this left shift is beneficial for us. So physiologically occurs with decreased oxygen needs, that is decreased temperature. And pregnancy, fetal hemoglobin is higher O2 affinity than adult hemoglobin, and increased O2 binding due to decreased affinity for 2,3 BPG. So that will cause left shift driving O2 across placenta to fetus. So physiologically, there are two causes. The first is decreased temperature, and the second is pregnancy. So in pregnancy, there is increased fetal hemoglobin, right? And fetal hemoglobin always has higher oxygen affinity. So that would lead to decreased unloading of the oxygen from hemoglobin. And there's going to be increased oxygen binding, right, due to decreased affinity for 2,3 BPG. So these are the two causes that decreased O2 needs, the physiological causes, that is decreased temperature, and second is pregnancy. So fetal hemoglobin has higher affinity for O2 than the adult hemoglobin, and that increased O2 binding is due to decreased affinity for the 2,3 BPG, right? So there is going, if there's less 2,3 BPG to bind to hemoglobin, there's going to be increased binding capacity for oxygen for fetal hemoglobin. That will cause left shift. Okay. And because the fetal hemoglobin has higher O2 affinity, it is easier to transfer oxygen across placenta to the fetus through fetal hemoglobin. Right? And pathologically occurs with increased carbon monoxide, increased methemoglobin, genetic mutation with decreased 2,3 BPG, so the left is lower. Right. So with increased carbon monoxide, there is going to be strong binding of hemoglobin to oxygen, right? With increased methemoglobin in itself has more oxygen affinity than the normal hemoglobin, right? And genetic mutations, that is decreased 2,3 BPG. So left stands for lower, and left also stands for loading of O2 into hemoglobin. So in other words, the binding is increased, and in right shift, unloading is increased. ODC has a sigmoidal shape due to positive cooperativity, that is, tetrameric hemoglobin molecule can bind 4 O2 molecules and has higher affinity for each subsequent O2 molecule bound. So the binding of the first O2 molecule is a little bit difficult, but as more and more O2 molecules start binding the hemoglobin, the fourth O2 molecule will be the easiest to bind to. Right? So myoglobin is monomeric and thus does not show positive cooperativity. Curve lacks sigmoidal appearance. So hemoglobin has 4 what is that? 4 polypeptides, right? And myoglobin has just single polypeptide, right? So in hemoglobin, the O2 will bind first here, and then here. So the affinity of O2 to hemoglobin keeps on increasing as it binds more and more hemoglobin polypeptides. But in myoglobin, there is just single polypeptide, and then there are different molecules with single polypeptides. So oxygen will keep binding at its own rate. There is not going to be any change in the rate of oxygen binding to the myoglobin. Hence, the curve is very steep. And for hemoglobin, it is a sigmoidal. Right? Now, response to high altitude. Response to high altitude. There's constant FiO2, but Pb decreases. So what was Pb? So just remember that atmospheric oxygen is, I haven't even given it this a thought, but I still know the concept. So you guys too don't need to focus whatever this is, but just decrease atmospheric pressure, decreased atmospheric oxygen in high altitudes, that is PiO2. So if the PiO2 is low, the PaO2 is also going to be low. And if the PaO2 is low, there is less oxygen pressure in the alveoli, the body will start hyperventilating. And we all know that the most common consequence of increased hyperventilating is decreased PaCO2 or hypocapnia. More and more CO2 is exhaled out of the body. So if the CO2 is being decreased from the blood, it is going to cause respiratory alkalosis. Right? Because as we saw here, that if there is increased carbon dioxide in the body, it is going to bind to increased hemoglobin, and more hemoglobin H plus is going to dissociate from it and will lead to acidosis. In the same way, if the CO2 is decreasing, more and more H plus is going to bind to hemoglobin, and the level of H plus from blood is going to decrease, causing alkalosis, and it is due to a respiratory cause. So this is respiratory alkalosis, which is known as altitude sickness, that is headache, nausea, fatigue, lightheadedness, and sleep disturbances. So you don't have to keep in mind these symptoms, and the question stem, it will obviously be given that the patient has moved to a higher altitude, and there is chronic increase in ventilation. Right, so let's just write it down in our own words. the PiO2 is decreased, PaO2 decreases, that is going to cause hypoxia. This is hypoxemia. This is going to cause hypoxia. And now everything that's going to be there, it's because of the hypoxia. We are going to see different changes that occur in the body, that is only because of this hypoxia. And so first of all, due to hypoxia, as we saw, there is going to be hyperventilation. Hyperventilation causes the most common consequence, that is decreased PaCO2, that is respiratory alkalosis. Because if there is low carbon dioxide, there is going to be more H plus binding to hemoglobin, which will cause less H plus in the blood, which will cause alkalosis. Right. And what is the compensation of respiratory alkalosis? The body just has to get rid of the excess bicarbonate, right? So bicarbonate is alkaline, so body just has to get rid of the bicarbonate, right? So in respiratory alkalosis too, the bicarb is going to increase, because that's how carbon dioxides get so body will lose excess bicarbonate through kidney. So that is going to cause another consequence in chronic patients, that is after a few days of living in higher altitude, the bicarbonate level in the body will start decreasing. After living in high altitudes. This was a question in Uworld, right? So the bicarbonate levels are higher in patients that has gone to live in the higher altitudes, not the people already living in high altitude since longer times, but just the people that move to the higher altitudes, right? Now the second thing, hypoxia always leads to increased erythropoietin, and increased erythropoietin is going to cause increased hemoglobin. And the third, hypoxia leads to increased 2,3-DPG. And what happens when there is increased 2,3-BPG? Here we saw that if anything increases, be it H plus 2,3-BPG, temperature or CO2, there is going to be increased hemoglobin unloading. Right. And also chronic consequence of hypoxia is right ventricular hypertrophy and pulmonary hypertension. Right. So yeah, these four things are happening due to hypoxia. The first is respiratory alkalosis. As a result of it, bicarbonate levels are decreasing in patients living in high altitudes, right? The second is increased hemoglobin due to increased erythropoietin. Third is increased hemoglobin unloading due to increased 2,3-BPG, and the fourth is RVH and pulmonary hypertension. Yeah, so see, there is increased erythropoietin, increased hematocrit and hemoglobin due to chronic hypoxia. Increased 2,3-BPG binds to hemoglobin, rightward shift of oxygen hemoglobin dissociation curve, that is unloading of the hemoglobin. increased O2 release, cellular changes. Yeah, so this is new, that the mitochondria also increase in number. There's renal excretion of bicarbonate to compensate for respiratory alkalosis, can augment with acetazolamide, and chronic hypoxic pulmonary vasoconstriction, increase pulmonary vascular resistance, because during hypoxia there is also pulmonary vasoconstriction, and if any vessel is vasoconstricted for chronic period of time, it is going to cause hypertension. So if the pulmonary vessels are being vasoconstricted, it is going to cause pulmonary hypertension, right? And the pulmonary hypertension leads to right ventricular hypertrophy, because right ventricle has to work harder to push blood through the vasoconstricted pulmonary vessels, right? So it undergoes hypertrophy. Right, so why is renal excretion of bicarbonate is augmented with acetazolamide? Because the mechanism of action of acetazolamide is in itself increasing the bicarb excretion, right? So if the patient is on acetazolamide, the bicarbonate levels can decrease way more, right? And also there's effect of hypoxia leads to suppression of zona glomerulosa, which is going to cause aldosterone suppression. You just have to remember this. So we saw about the response to high altitude, but now let's see the response to exercise. So during exercise, we all know that heart rate increases, stroke volume increases to maintain the cardiac output, right? So as the stroke volume is increasing, there's going to be increase in the perfusion, right? And increase in perfusion is increase in pulmonary blood flow. So the VQ ratio increases from base to apex, that is becomes more uniform. So right, so the perfusion, the Q was earlier less, but now the Q starts increasing a little bit, right? So the VQ ratio increases from base to apex, that is relatively from base to apex, okay? Increase cellular respiration, it will also cause increase in carbon dioxide production, and whenever there is increase in carbon dioxide production, there is going to be increase in H plus as well. Now that we know, we should make it a rule of thumb that whenever carbon dioxide increases, H plus is going to increase and acidosis will take place, right? So as the H plus is increasing, there is decreased pH, the same thing, and as the H plus is increasing, and there is going to be right shift of ODC, so tissue offloading of more O2, right? So we needed O2 during for our response towards exercise for increasing the cellular respiration, and now we have got O2, we have got more offloading of O2 from hemoglobin, and as more O2 is being offloaded, that O2 is going to be consumed, and there is going to be increased respiratory rate to meet the increased oxygen demand and remove the excess CO2, right? We need O2 consumption, the O2 consumption is increased, so we need O2, and we are producing so much of carbon dioxide now, which needs to get excreted, right? So increased respiratory rate will do both of those things. So PaO2 and PaCO2 are maintained by homeostatic mechanisms, and PvO2 decreases due to increased O2 consumption, and PvCO2 due to increased CO2 production, right? So the oxygen in venous blood is going to decrease, right, because of increased O2 consumption or increased O2 extraction from the arterial blood. If this is the arterial blood, this is the venous blood, and this is the organ that needs oxygen, right? So now that organ is going to extract more of the oxygen from the arterial blood and very less O2 compared to previous normal at rest situation. There is going to be less PvO2, right? And organ, after using more of oxygen, after extracting too much of oxygen, is going to produce equivalent amounts of CO2, which is higher than being at rest. So that CO2 is going to travel through venous, so the PV CO2 is going to increase, right? Right, so now let's again understand things in our own way, like we did in altitude. So it is very easy, it's very straightforward, like it's just everything is given here. I'm just going to write it down again and add a few things along the way. So exercise is increasing the heart rate, increasing the stroke volume, increasing the oxygen consumption and oxygen reaching the tissues. And if the oxygen consumption is increased, CO2 production is also going to be increased. And whenever CO2 is increased, there is going to be H plus production. And whenever there is increase in H plus, there is going to be unloading of O2. Right. So now, as the tissue needs more O2, as the cellular respiration is increased, the cells are going to need more of O2, right? So there is demand of O2 created. There is demand of O2 created. You know about the demand and supply, right? So demand is created. Now for the supply part, respiratory rate has to increase. So increased respiratory rate is going to provide oxygen as well and is going to help us excrete the carbon dioxide as well, right? So everything that happens to us while we exercise is explained by this mechanism, that our respiratory rate increases, our heart rate increases, stroke volume increases, and if we even calculate the the venous O2, there is going to be increased there's going to be decreased O2 in the venous system, right? Because more of oxygen is being extracted from the arteries. Now we discussed about the response to high altitude, response to exercise. Now we should also discuss the response to aging, right? So what happens with aging? Because there are 2 or 3 questions that I can remember from the question bank that are based on the aging. And so with aging, first of all, the compliance is going to increase. So in like basic words, you can remember the changes with aging just like the changes in COPD. Right? It is a bit similar to what happens in COPD. So in COPD2, the compliance increases and the elasticity decreases. The lungs are now stiff, the walls are now stiff, so there is going to be air trapping. And because air trapping is the work of breathing is going to increase, right? And just like emphysema and everything, there is going to be increase in AA gradient. And just like COPD, the PaO2 is also going to decrease because the oxygen can't diffuse as easily in the PaCO2 is almost normal, right? So this is a point of difference between COPD and the aging, right? But it's not that big of a difference. We will see how. So PaCO2 is somewhat normal because, as we saw earlier here, then disease states that lead to diffusion limitation, example pulmonary fibrosis, are more likely to cause early hypoxia than hypocapnia, right? Because diffusion of CO2 is easier than diffusion of O2. So hypoxia develops earlier in the stage of disease, or in this case in the stage of aging, right? And the hypercapnia takes some time, right? So but with aging, it's not that severe of a case if it's a normal lung with aging. So the hypercapnia almost never develops, right? So because it takes time, and CO2 diffuses because CO2 diffuses easily. Oxygen can't diffuse that easily, but CO2 is able to diffuse out easily, right? So there is going to be hypoxia but no hypercapnia. There is also the case in mild cases of COPD, right? Or in the early stages of COPD. But COPD has more tendency to convert into a severe form, right? And in severe form, there is hypercapnia too. It's COPD is called a hypercapnic state, right? There is CO2 trapping, right? And that is why we say that the respiratory centers in the brain get used to the increased CO2 levels in the blood, so they stop responding to the increased CO2 levels. So the ventilation is driven by oxygen, by the hypoxia of the body, right? So normally hypoxia does not stimulate the respiratory centers as well as the hypercapnia does, but due to the chronic increase in the carbon dioxide in the COPD stages, the respiratory centers stop responding to the increased carbon dioxide, and rather they respond to the hypoxia state, right? So hypoxia is the one driving the respiration in COPD patients, right? So even if we provide supplemental O2 in COPD patients, we have to be careful, right? Because it's the hypoxia that is keeping the patient alive, and if we are administrating more oxygen, the respiratory centers might turn off, right? So we have to be very careful in providing the volume of oxygen, right? I don't know the exact exact oxygen pressures that are given, but it's something around 4 to 5 liter per of oxygen, but I'm not at all sure about it. Right? So do check it out yourself if you want to, but it's no need here, right? That's not needed here, right? So and also keep in mind the thumb rule that I just said. Whenever CO2 increases, whenever CO2 increases, there is going to be increase in H plus, and it is going to be acidotic state. Just keep this in mind and you'll be able to answer many of the questions if you know these mechanisms: response to high altitude, response to exercise, and this AA gradient thing. And all these topics together can make a single question, right? So all these concepts are interconnected with each other. Yeah, so now methemoglobin. Methemoglobin, iron in hemoglobin is normally in reduced state, that is in ferrous state, 2 of us Fe2 plus. Oxidized form of hemoglobin, ferric 3 plus, does not bind to oxygen as readily as Fe2 plus, but has increased affinity for cyanide. Right. So tissue hypoxia may from decreased oxygen saturation and decreased O2 content. This ferric ion form is called methemoglobinemia. While typical concentrations are 1 to 2%, methemoglobinemia will occur at higher levels and may present with cyanosis. It does not improve with supplemental O2, right, and with chocolate colored blood, because methemoglobin is somewhat darker than the regular hemoglobin. Dapsone local anesthetics like benzocaine and nitrites from dietary intake or polluted water sources causes poisoning by oxidized ferrous to ferric ion. Right. So these dapsone and local anesthetics and nitrites, they convert Fe2 to Fe3 plus. So that is going to form methemoglobin. Right. So methemoglobin can be treated with methylene blue and vitamin C. So as methemoglobin is being formed, the previous normal hemoglobin used to bind to oxygen, right, with Fe2 plus, but now with methemoglobin, that is Fe3 plus, it is going to bind cyanide easily, right, and so oxygen will have no place with hemoglobin, so there is going to be decreased O2 content in the blood. Right. Right, the last topic of physiology. Things get way more fun in pathology, right? Cyanide versus the carbon monoxide poisoning. So they both inhibit aerobic metabolism via inhibition of complex 4 of ETC. That is cytochrome C oxidase. It will cause hypoxia that does not fully correct with supplemental O2 and decrease anaerobic metabolism, because it is not about the concentration of the hemoglobin or the oxygen that is at problem here, but it is about the affinity of the oxygen and affinity of cyanide and carbon monoxide to the hemoglobin. That is a problem here. So it doesn't matter how much of supplemental O2 we provide, that is not going to reverse just by giving supplemental O2, right? We need something that is way more powerful than carbon monoxide to replace it with hemoglobin, right? So the oxygen can have more space to bind with the hemoglobin, right? We'll discuss all of this again as we go through this topic. So the first is cyanide. It is a synthetic product combustion. How is exposure to cyanide occurring? Through the synthetic product combustion, amygdalin ingestion, it is found in apricot seeds, and cyanide ingestion, that is in suicide attempts and fire victims. And the carbon monoxide exposure is taken from motor exhaust, gas heaters, and fire victims. So presentation of cyanide poisoning is headache, dyspnea, drowsiness. seizures, coma, and it may have cherry red skin, that is pathognomic, and breath may have bitter almond color, odor, sorry. And the carbon monoxide presentation is headache, vomiting, confusion, visual disturbances, and coma as well. And may have cherry red skin with bullous skin lesions. Multiple victims may be involved, that is family due to faulty furnace, right? So there may be multiple victims. Now the labs show that cyanide poisoning has normal PaO2. There is although elevated lactate, that is anion gap metabolic acidosis. Okay, so the PaO2 is going to be normal, and in carbon monoxide too, the PaO2 is going to be normal, although there is elevated carboxyhemoglobin on co-oximetry. Classically associated with bilateral globus pallidus lesions on MRI, although can be rarely seen with cyanide toxicity too. Like this is the globus pallidus lesions, GP lesions on MRI. Effect on oxygen hemoglobin curve. The curve is normal with cyanide poisoning. Oxygen saturation may appear normal initially despite ample O2 supply. It cannot be used due to ineffective oxidative phosphorylation. So the problem isn't in the inspired air, the problem isn't in the diffusion of the oxygen, the problem isn't even in the binding of the binding of hemoglobin to oxygen. The problem is in the mitochondria, where the cellular respiration occurs. The problem is in the complex 4 of the ETC, that is electron transport chain. So cyanide and carbon monoxide both inhibit the complex 4 of ETC. So the oxygen is not able to travel through the membrane of the mitochondria, right? So despite ample O2, even if we give enough of oxygen, when there's inhibition of the complex 4 of the ETC, no amount of oxygen can diffuse through that, right? And in carbon monoxide, there is left shift in ODC, that is increased affinity for oxygen. So decreased O2 unloading in tissues bind competitively to hemoglobin with more than 200 times greater affinity than oxygen to form carboxyhemoglobin. So the oxygen saturation of hemoglobin is going to decrease. Right. Yeah. So carbon monoxide also inhibits complex 4 of ETC just like cyanide. But in addition to that, it also has 200 times greater affinity to hemoglobin than oxygen. So oxygen saturation is also going to decrease. Right. The treatment is for cyanide poisoning is decontamination, that is remove clothing. Hydroxycobalamin, it binds cyanide and forms cyanocobalamin, and it is going to be excreted renally. Then there's nitrites, that is going to oxidize hemoglobin into methemoglobin, and that methemoglobin then binds cyanide, so it forms cyanomethemoglobin, which has reduced toxicity and hemoglobin can be saved. The third is sodium thiosulfate, increased cyanide conversion to thiocyanide, and that is going to be excreted renally. And for carbon monoxide, we just have to give 100% of oxygen, and we even have to put the patients into a hyperbaric oxygen chamber. So hydroxycobalamin, nitrites, and sodium thiosulfate. So if this is the normal curve of the hemoglobin and oxygen dissociation, in carbon monoxide there is going to be left shift, that is increased loading of oxygen with hemoglobin, or in other words increased binding of O2 to hemoglobin. Right, so as you can see, this is the left shift of the curve. So now we'll move on to the pathology section. So the pathology of respiratory system is a little bit easier than the other organ systems, right? But uh, whichever questions the physiology too is involved, it complicates the questions a little bit, right? But if it's purely a pathological question, it's going to be easy, right? Yeah, so the first is rhinosinusitis. It is the obstruction of sinus drainage into nasal cavity, which can lead to inflammation and pain over the affected area. Right? So typically affects the maxillary sinus, which drain against the gravity due to ostia located supromedially. Red arrows point to fluid-filled right maxillary sinuses in A. So this is the maxillary sinus and it is fluid-filled, as we can see here. And it has to drain against the gravity due to ostia located supromedially. Right, so this is the supromedial ostia, so it has to drain anti-gravity. Right, so superior meatus drains the posterior ethmoid. Middle meatus drains frontal, maxillary, and anterior ethmoid, and inferior meatus drains the nasolacrimal duct. Right, so if these are the meatus, superior, medial, and middle and inferior. Superior meatus drains the posterior ethmoid. Middle meatus drains frontal, maxillary, and anterior ethmoid. And the inferior meatus drains the nasolacrimal ducts. Right. Acute rhinosinusitis is most commonly caused by virus, that is rhinovirus. Rhinovirus is the most common cause, may lead to superimposed bacterial infection, most commonly non-typical H. influenza, strep pneumo, or M. catarrhalis. H. influenza, strep pneumo, and M. catarrhalis. Paranasal sinus infections may extend to the orbits, cavernous sinus, and brain, causing complications like orbital cellulitis, cavernous sinus syndrome, and meningitis. Epistaxis is, in layman terms, is the nosebleed. So most commonly occurs in the anterior segment of the nostril from Kieselbeck plexus. It is life-threatening. Hemorrhages occurs in posterior segment. So commonly it is in the anterior segment, but in posterior segment it can be life-threatening. And common cause include foreign body trauma, allergic rhinitis, and nasal angiofibromas. That is common in adolescent males. Right? Nasal angiofibromas are common in adolescent males. Kieselbeck drives his Lexus with his legs, so that is a mnemonic for superior labial artery, anterior and posterior ethmoidal, greater palatine and sphenopalatine, so that is legs. Right, and if you don't want to remember this weird kind of mnemonic, weird kind of irrelevant mnemonic, you can just remember kiss the legs. I guess that is, this mnemonic is way more weirder, but it does the work. Right, so Kieselbeck and labial artery, anterior and posterior ethmoidal, greater palatine, and sphenopalatine. Now, head and neck cancers, mostly squamous cell carcinoma. Risk factors include tobacco, alcohol, HPV 16, oropharyngeal, and EBV, that is nasopharyngeal. So, tobacco is the biggest risk factor for head and neck cancer, uh, mostly in India, but we are giving Usmle, so we have to keep in mind all these risk factors. But in India, it's generally tobacco that is causing the head and neck cancers, mostly the oral cancer and the tongue cancer and everything like that. And it can cause field cancerizations, that is carcinogen damages wide mucosal area, multiple tumors that develop independently after exposure. So nearby cancers develop from primary cancer, right? So nasopharyngeal carcinoma may present with unilateral nasal obstruction, discharge, and epistaxis. Eustachian tube obstruction may lead to otitis media, effusion, and hearing loss. Laryngeal papillomatosis is also called recurrent respiratory papillomatosis. Common benign laryngeal tumor of vocal cords, especially in children. It is associated with HPV 6 and HPV 11. Now, the deep venous thrombosis, blood clot within a deep vein causes swelling, redness, warmth, and pain, and it is predisposed by Virchow's triad. And these signs are pretty obvious in the patient. Like if you have seen a patient of DVT and if you tried touching their leg, you can feel that is warm, right? It is even warmer than the feverish body, right? You can obviously make out that it's a DVT. Yeah. And the Virchow's triad consists of stasis, hypercoagulability, and endothelial damage. Stasis due to post-op, long drive, flight, mostly long drives and flights history will be given, right, in the question stem. Hypercoagulability, that is defect in coagulation cascade proteins such as factor 5 laden, oral contraceptive use, pregnancy, and endothelial damage. Exposed collagen triggers clotting cascade. Most pulmonary emboli arises from the proximal deep veins of lower extremity, that is iliac, femoral, and popliteal veins. D-dimer test may be used clinically to rule out DVT if disease probability is low or moderate. And it is also used for pulmonary embolism testing, this D-dimer test. And it has high sensitivity and low specificity. Imaging test of choice is compression ultrasound with Doppler, right? And use unfractionated heparin or low molecular weight heparins, that is enoxaparin, for prophylaxis and acute management. And direct anticoagulants like rivaroxaban, napixaban for treatment and long-term preventions. So heparins for acute and rivaroxabans and napixabans for long-term. And if it's a massive pulmonary embolism, we have to give streptokinase, right? Now, pulmonary emboli. So obstruction of the pulmonary artery or its branches by foreign material is usually thrombus that is originated elsewhere. So if it's stationary, it is called thrombus, and once it comes into the circulation, it is lodged into the circulation, it is called emboli, and that emboli lodges the pulmonary artery system. Affected alveoli are ventilated but not perfused, so Q becomes 0 and V is normal, so VQ ratio becomes infinite. May present with sudden onset dyspnea. This is a very important term, that is sudden onset dyspnea, pleuritic chest pain, tachypnea, tachycardia, hypoxemia, and respiratory alkalosis. Large emboli or saddle embolus. This may cause sudden death due to clot preventing blood from filling the left ventricle and increased RV size, further compromising LV filling. That is called obstructive shock. Right, so large emboli can either prevent the blood from filling the LV, so it can obstruct either the pulmonary vein, or it can be, the pulmonary embolus can be so big that the RV has to apply more and more pressure to fill that pulmonary artery, which is embolized. So increased work on right ventricle leads to compromised left ventricle filling, right? That is obstructive shock. And yeah, why is respiratory alkalosis there? It may be due to the tachypnea that is occurring in pulmonary emboli, right? Whenever there is hyperventilation, there is going to be decreased PaCO2, and decreased PaCO2 means decreased H+, and that causes respiratory alkalosis. CT pulmonary angiography, CTPA, is imaging test of choice for pulmonary embolism. Look for filling defects. Right? ECG may show sinus tachycardia, or less commonly S1 Q3 T3 abnormality, but it is very less common. So what is S1 Q3 T3 abnormality? It is I think in V1 S wave is elevated, in V3 Q and T waves are elevated or something like that. We just have to right. So S1 Q3 T3 is in lead 1 the S wave is enlarged, in lead 2 the Q wave is enlarged, and in V3 the T wave is enlarged. Right? So it's not elevated, but it's a large S wave. It's a large S wave in lead 1, a large Q wave in lead 2, and inverted, not in 2 but in lead 3, and inverted T wave in lead 3 as well. Right, so there are lines of Zan that can be seen, are interdigited areas of pink. Pink area is made of platelet and fibrin, and red, that is made up of RBCs found only in thrombi formed before death. Help distinguish pre and post-mortem thrombi. So is that, yeah, so these are the pink and red lines. So pink lines are formed by platelet and fibrins, and red line is formed by RBCs. And what is the treatment? Treatment is anticoagulation. Anticoagulation consists of heparin, direct antithrombin, direct thrombin, factor 10A inhibitors, IVC filters if anticoagulation is contraindicated. When can anticoagulation be contraindicated? When there's a recent history of brain hemorrhage or something like that, like, or if the patient's age is very young, anticoagulation may be contraindicated. So what are the types of embolism? Fat, air, thrombus, bacteria, amniotic fluid, tumor. These all are the types of blood embolism, out of which the fat and and thrombus are the most asked embolisms. Embolus moves like a fat bed. Fat emboli, it is associated with long bone fractures and liposuction, classical triad of hypoxemia, neurological abnormalities, and facial rash. This is a very important thing to look out for in question stamps. Air emboli it's not asked much, but nitrogen bubbles precipitate in ascending drivers. It is Caisson's disease and decompression sickness. Treat with hyperbaric O2 or can be iatrogenic secondary to invasive procedures like central line placement. And amniotic fluid emboli is typically occurs during labor or postpartum, but can be due to uterine trauma. It can lead to DIC. It is rare but high mortality. The mediastinal pathologies. So normal mediastinum contains heart, thymus, lymph nodes, and esophagus and aorta. So mediastinal mass are some pathologies that are lymphoma, lung cancers, abscess, can occur in any compartment, but there are common associations like in anterior mediastinum there can be just 4 T's, that is thyroid, thymic, teratoma, and terrible lymphoma. Right, so so if it's a thyroid swelling, it is going to be substernal. In thyroid, only substernal goiter can present as anterior mediastinal mass, right? And then there's thymic neoplasm, teratoma, and terrible lymphoma. And in the middle mediastinum, there's esophageal carcinoma, metastasis, hiatal hernia, and bronchogenic cyst. And in posterior, there is neurogenic tumor called neurofibroma and multiple myeloma. Now, what is mediastinitis? Mediastinitis is inflammation of the mediastinal tissues, commonly due to the post-operative complications of cardiothoracic procedures in less than 14 days. So this is a common post-op complications. Like I've seen cases myself where when I used to work in a heart hospital, the post-op complication of cardiothoracic procedures was mediastinitis, right? And it can also be due to esophageal perforation or contagious spread of odontogenic or retropharyngeal infections. Chronic mediastinitis, also called fibrosing mediastinitis, due to increased proliferation of connective tissues in mediastinum, and histoplasma capsulatum is a common cause. Right, so any chronic condition can cause fibrosis, right? So chronic mediastinitis will be causing fibrosing mediastinitis due to increased proliferation of connective tissue in mediastinum. And histoplasma capsulatum is a common cause. Histoplasma is such an important topic for USMLE that when you will do Uworld for RS, there's going to be a ton of questions from histoplasma, but luckily all the histoplasma is being covered in the microbiology section, right? So we don't have to go through it here. But yeah, there are certain signs and symptoms of histoplasma which should be very eye-catching for you. So the first is like the lung fibrosis. Then there's a history of exploring caves. Then there's, I think, erythema nodosum is there. And yeah, the history of location can be given, that is Ohio and Mississippi. Valley. in US. Right, so which are these Ohio and Mississippi areas? So the Mississippi and Ohio are the rivers in the US, and it mostly consists of the Central America regions. If this is the map of North America, all these states here in the Central North America consist of Ohio and Mississippi rivers. So histoplasma is very common in those areas. Right, so clinical features of mediastinitis is fever, tachycardia, leukocytosis, chest pain, and sternal wound drainage. Right. Pneumomediastinum is presence of gas, usually the air in mediastinum. It can either be spontaneous due to rupture of pulmonary bleb, that is in tall people, tall thin males. The spontaneous pneumomediastinum is common, and secondary trauma, iatrogenic Boerhaave syndrome, and ruptured alveoli. Tracking of ruptured alveoli allows tracking of air into the mediastinum via peribronchial and perivascular sheaths. And clinical features are chest pain, dyspnea, voice change, and subcutaneous emphysema, and positive Haman's sign or Haman's crunch. There's crepitus on cardiac auscultation, that is a crunch like sound, that is called Haman's crunch. There's chest pain, there's dyspnea, there's voice change, and there's subcutaneous emphysema. Right. And there can be a history of Boerhaave syndrome. What is Boerhaave syndrome? It is due to excessive drinking, that is just laceration, complete laceration of lower esophagus, which can let the air out of it. Right. There's Boerhaave syndrome, and then there's Mallory-Weiss tear. In Mallory-Weiss tears, there's just longitudinal lacerations, and they are not complete, like they don't perforate esophagus. But in Boerhaave syndrome, due to forceful vomiting against a closed esophagus after alcohol drinking, it can lead to complete perforation of the lower esophagus. So that can also lead to pneumomediastinum. And the rupture of pulmonary bleb can be in tall, thin males who smoke. Right? Pulmonary blebs develop commonly in the smokers. The flow volume loops, I don't know why this section is kept here. This should be in the physiology section, but anyway, let's just go through this. It appears very difficult, but trust me, it's very easy topic. So we know that obstructive lung disease is an expiratory problem, and restrictive lung disease is an inspiratory problem, right? Restrictives have problem inspiring. They can't inspire people much, right? So obstructive lung disease, the residual volume obviously is going to increase because the patient can't expire all the air, right? And FRC is also going to increase, TLC is also going to increase. Like every capacity and every volume that is related to the patient expiring is going to increase, right? Because the patient can't expire. So RV is just the volume of air that is always in the lungs, so that increases. FRC increase because patient can't expire. In TLC, we should talk about why TLC increases, because TLC, as you know, is volume in lungs after maximum inspiration, right? So patient can inspire normally, right? At least in textbooks, right? So patient is able to inspire normally, but there is also the residual volume that is being increased, so TLC is also going to increase, right? So TLC is vital capacity plus RV. So if RV is increased, TLC is also going to increase, but TLC does not increase as much as the residual volume does, right? So somewhere there is a graph in Uworld that goes like this. This is the volume and this is the normal person's TLC and RV. The COPD patient's graph will be somewhat like this. So as you can see, the RV has increased so much, but the TLC hasn't increased that much, right? So they are going to give you RV by TLC ratio. So if RV is increasing too much and TLC is increasing a little bit, the ratio is going to increase in COPD. Right. And FEV1 is the expired air in the first second of all the 6 seconds of expiring, right? So that FEV1 is going to decrease because it's obviously an expiring problem. Then there's FVC. The total FVC is also going to decrease, and FEV1 by FVC is going to decrease because FEV1 is decreased more than the FVC, because most of the air is expired in the first second of the FVC, that is the FEV1. Most of the air is expired in FEV1 in normal patients, but in COPD the person can't exhale that much amount of air that quickly in the 1 second itself. So FEV1 is going to drop more rigorously than FVC. Right, so restrictive lung disease, the residual volume is going to decrease, FRC decrease, TLC decrease, FEV1 decrease, FVC decrease. Right, because if we are now looking at practical tests which shows us that patients who have problem inspiring also have problem expiring, right? It was just for textbooks that there's inspiratory problem with restrictive lung disease and expiratory problem with obstructive lung disease, but in reality the patients who have difficulty inspiring will also have difficulty expiring the same amount of air, right? Because if you are inspirating this much amount of air in normally, you are going to inspire just this amount of air in restrictive lung disease, and you are going to exhale the same amount of air which is less than what you should exhale normally, right? So FEV1 is going to decrease, FVC is going to decrease, and both of them are decreasing at the same rate. FEV1 is not decreasing rigorously, so the ratio may be normal or even increased a little bit because FEV1 decreased proportionally to FVC. Yeah, these loops are very easy to remember. Like in obstructive it moves to left and becomes smaller, in restrictive it moves to right and becomes smaller. And why does it move to left in obstructive? Why does the loop shifts to left? Because the volume and capacities increase in obstructive lung disease. So as you can see, the earlier was 6 liters per second, now this is 8 liters per second, right? And this was the normal expiration, 8 liters, now it is just around 4 liters. And here it was 4.5 something, now it is 4. So why is there a left shift? Because of the air trapping. More and more air trapping is there, more and more volume and capacity is going to increase, right? In restrictive, it moves to right, so volume and capacities decreases. So here you can see the inspiration was normally 4.5. Now it's just around 1. So inspiration is more affected, and on the same hand expiration is also a little bit affected. And now the obstructive lung disease, obstruction of airflow, that is all the capacities are going to increase, not all, but FRC, RV and TLC. So there's air trapping in lungs with premature airway closures at high lung volumes. There's premature airway closure that will lead to air trapping. At FEV1 is reduced, FVC decreased, FEV1 and FVC ratio is decreased, leads to VQ mismatch obviously. Right, so this emphysema, the ventilation is going to decrease, not the perfusion part. Right, the perfusion may get increased in asthma, as we talked about, right, about in the DLCO, when we were discussing that DLCO section. Right? In emphysema, there's barrel-shaped chest. The AP diameter has increased. Expiration is prolonged or through pursed lip. So why is it pursed lip? To decrease the respiratory rate and decrease the work of breathing. Because the elastic recoil has increased in emphysema, so we have to slowly exhale the air so that the alveoli doesn't collapse at all of a sudden, right? So to prevent alveoli from collapsing, we let the air out gently, right? And the respiratory rate is decreased. On the other hand, in RLD, the respiratory rate is increased. There's short, shallow breaths, right? Yeah, so through pursed lips, increased airway pressure and airway collapse, prevents airway collapse. There can be century SNR, pan SNR. Okay, right, just 2 of them. So century SNR affects respiratory bronchioles while sparing distal bronchi associated with tobacco smoking, frequently in upper lobes. Smoke rises up. So yeah, this diagram is pretty good. So it affects the respiratory bronchioles, not the distal alveoli. But pan SNR will affect respiratory bronchioles as well as the distal alveoli. And century SNR, CS, smoking, and smokes always rise up, so upper lobes are affected. And pan SNR affects respiratory bronchioles and alveoli associated with alpha-1 antitrypsin deficiency. And they are not smokers. So people who are not smokers can be affected by emphysema by which condition? That's alpha-1 antitrypsin deficiency. Right. It's either smokers or alpha-1 antitrypsin deficiency. And it is frequently in lower lobes. Enlargement of air spaces, it decreases recoil, it increases compliance. So increased compliance means easy filling of the lungs, so that is causing the air trapping. Decreased DLCO from destruction of alveolar walls, right? We discussed about this. And decreased blood volume in pulmonary capillaries. Right. So imbalance of proteases and antiproteases. That is the pathology behind emphysema. So there is increased elastase activity, which will increase the loss of elastic fibers. It is elastase, right? So it will cleave down the elastic protein in the alveolar walls, right? So there is going to be increased lung compliance. And these antitrypsin, alpha-1 antitrypsin is an antiprotease. So if antitrypsin is deficient, the elastase activity is going to increase. In chest X-ray, we can see that the AP diameter is going to increase flattened diaphragm due to hyperinflation of the lungs. So lungs will be found to be more elongated because they are hyperinflated. If this is a normal lung, this is what it will look like on chest X-ray. The diaphragm will be flattened. Increased lung field lucency, and chronic inflammation is mediated by CD8 plus T cells, neutrophils, and macrophages. And yeah, so let's add a few things up, a few characteristics of emphysema. So there isn't going to be any kind of cyanosis, first of all. The TLC is going to increase because it's an obstructive pathology. The DLCO decreases because, yeah, let's discuss why DLCO decrease. We can also think like, although in most diseases, although in most lung diseases, the DLCO decreases, right? Except in asthma where DLCO increases. But some people might also think that DLCO should increase in emphysema as well because there's air trapping. Because I thought I had a doubt like this. Because when we give PEEP in pulmonary edema or that, we tend to make a closed circuit of air, right, to make sure the oxygen travels across the alveolar walls. The same thing is there somewhat, same thing is there in emphysema as well because there's air trapping, right? But so as there's air trapping, the air should be pushed towards the alveolar walls more, right? So there should be effective increased diffusion of O2 across the alveolar wall. But it doesn't happen like that because even if there's air trapping, but the effective surface area for exchange in alveoli has decreased, right? Effective area of alveoli to transfer has decreased. Because if this was alveoli and these are the type 1 cells and this is type 2 cells, what happens in alveoli are they are now hyperinflated, right? And the same amount of O2 that was being diffused across this border will get wasted along these spaces when alveoli are hyperinflated, right? O2 will go here as well and as well as here, but the O2 that is going at these spaces is going to waste, right? So this is called the effective area. This is the effective area for transfer of oxygen. So that decreases during hyperinflation of the lungs. Right. And also there's CO2 retention that we all know in COPD. And where CO2 is high, H plus is going to increase, that is going to cause decrease in pH, and to compensate that, the bicarbonate is being reabsorbed from the kidneys. Right, so that is called compensated respiratory acidosis. This pH is normal to low. that is called low normal, right? pH is not going to be of acidotic state, but it is going to be low normal. That's it. So now chronic bronchitis, the presentation is wheezing, crackles, cyanosis, and hypoxemia due to shunting. So what was hypoxemia? The PaO2 is decreased. There is decreased oxygen in blood, right? And what was hypoxia? It is decreased O2 delivery to the tissues. So there's hypoxemia due to shunting. And dyspnea, CO2 retention, secondary polycythemia, all that. Secondary polycythemia is due to the hypoxia. And pathology, and yeah, this is the key feature, but it's not asked much in Uworld, but it is just very clinical to know that there's cyanosis in chronic bronchitis, but it is absent in emphysema, right? Now the pathology, there's hypertrophy and hyperplasia of mucus secreting glands in bronchi. So that is measured by Reed index, that is thickness of mucosal gland layer to the thickness of wall between epithelium and cartilage, right? Some might mistook it for thickness of mucosal gland layer divided by the total wall, right? But it's not mucosal gland divided by total wall, right? It's very easy to misinterpret here, but let's see how the Reed index works. So the Reed index is mucus gland, thickness of the mucus gland divided by the submucosa plus lamina propria of mucosa. That is, the submucosa plus lamina propria of mucosa forms the space between epithelium and epithelium to cartilage. Right, so if this is mucosa, this is epithelium, then this is lamina propria, right? So this is mucosa, then there's submucosa where submucosal glands are there. So this will be the submucosal gland thickness, and then there's muscularis layer, and then there's going to be, what was there, mucosa, submucosa, muscularis, whatever, but there's cartilage beneath there, right? Underneath everything there's cartilage. So between epithelium to cartilage, layer to thickness of the wall between epithelium and cartilage. So everything that comes in between epithelium and cartilage is counted. Right, so there are questions that I've seen where most of the students have marked the answer wrong as thickness of mucosal gland to that of the whole thickness of the wall, but that's not the right thing, that it's thickness of mucosal gland to the thickness of wall between epithelium and cartilage. And if that is more than 50%, then we can say that it is a pathology of chronic bronchitis. And also in his histologically, we will see that there is thickened bronchial walls, plus gland enlargement that we just discussed about, and there's also going to be squamous metaplasia in bronchi. It is also caused by smoking. And the diagnostic criteria is productive cough for more than 3 months in a year for more than 2 consecutive years. And DLCO may be normal. Why is DLCO normal? Because the alveolar walls don't doesn't have any kind of problem. The issue is just in the bronchi, right? And TLC is going to be normal as well, right? Now, asthma, uh, the presentation is asymptomatic baseline with intermittent episodes of coughing, wheezing, tachypnea, dyspnea, hypoxemia, decreased inspiratory expiratory ratio. So, person will take more time to expirate than to inspirate, and mucus plugging. Some severe attacks may lead to pulsus paradoxus, and triggers are viral upper respiratory infections, allergens, and stress. Right, so pulsus paradoxus may be seen. What is pulsus paradoxus? It's just a drop in systolic BP by more than 10 mmHg during inspiration, or there can also be decrease in pulse rate during inspiration, and it's seen in asthma, COPD, and obstructive sleep apnea, and most importantly in cardiac tamponade. The pathology is hyperresponsive bronchi, uh, which undergoes reversible bronchoconstriction. Also, one more thing, in question stems, there will always and always will be intermittent episodes uh, for asthma, right? There won't be any question where you can see there is continuous coughing, continuous wheezing, tachypnea for this many days or this many months or anything like that. Although in very severe cases of asthma that might happen, but for the question stems, you always have to look out for the intermittent symptoms to diagnose asthma. Right. So yeah, there's smooth muscle hypertrophy and hyperplasia. There's Kirschmann spirals, that is F. This is the mucus plugging, right? This is mucus plugging. This is Kirschmann spirals. This Charcot-Leyden crystals. Right. Kirschmann spirals are made of shed epithelium, which forms whorled mucus plugs, and Charcot-Leyden crystals that are eosinophilic hexagonal double-pointed crystals formed from the breakdown of eosinophils in sputum. This is formed by breakdown of eosinophils in sputum. And Kirschmann spirals are formed by breakdown of epithelium. It's kind of a debris of epithelium. And the DLCO is normal or increased. We previously discussed why this is so, because there's going to be increased amount of pulmonary capillaries, so the perfusion is going to increase at the site of asthma, because it's an inflammation, right? One of the 4 characteristics of inflammation is rubor, that is redness. So that is going to be because of the increased pulmonary capillaries. Then there's also going to be air trapping, because there's bronchoconstriction, so the air distal to the bronchi is going to be trapped, which is going to apply more pressure towards the alveolar wall to support the diffusion of O2 across the wall. And it can be normal too, it's just increased in severe cases, right? It's not very specific. I just like to discuss about this DLCO thing so much, but it's not that high yield for saffron, right? It's a type 1 hypersensitivity reaction, which is hyperacute, right? And diagnosis supported by and there's mast cells which degranulate, right? And type 1, they are previously primed with the antigens. Diagnosis supported by spirometry and methacholine challenge. So methacholine mimics the effect of bronchoconstriction and all, and if the patient gets very critical during methacholine challenge, or it's his condition does his condition deteriorates during methacholine challenge, it is asthma. And NSAIDs exacerbated respiratory disease is a combination of COX inhibition, that is leukotriene overproduction, which causes airway constriction. Right? Chronic sinusitis with nasal polyps and asthma symptoms. So there's COX inhibition, there's chronic sinusitis with nasal polyps and asthma symptoms. Now the bronchiectasis, there's daily, the keyword is daily, it's not intermittent like in asthma. Daily purulent sputum, recurrent infections, mostly Pseudomonas aeruginosa, so there is very serious infection. Hemoptysis and digital clubbing is seen. So also I would like to add that there's foul smelling sputum, plus there's mid-inspiratory crackles, plus on chest x-ray you can see finger glove or tram track appearance. Due to dilated air spaces, right? If this is the lung, you will see appearance like somewhat like this. So this is like a finger glove appearance, right? And the two walls appear like it's a tram track. It is a chronic necrotizing infection of bronchi or obstruction. It permanently dilates the airways. It is associated with bronchial obstruction, poor ciliary motility, that is tobacco smoking, Carter-Jenner syndrome, and cystic fibrosis. Arrows in H shows dilated airway with mucus plugs. So yeah, this is the mucus plug in cystic fibrosis, and it can also be due to ciliary dysmotility like in tobacco smoking. So I just remember it that way, that if you smoke, the cilia are going to burn away. Right? Cilia are kind of hair kind of structures. So if there's too much of smoke or fire, the hair gets burned. So with smoking, the cilia are going to burn away. And in Carter-Jenner syndrome as well, allergic bronchopulmonary aspergillosis and pulmonary infections. So it can be associated with obstruction, smoking, Carter-Jenner, cystic fibrosis, ABPA, and pulmonary infection, that is Mycobacterium avium. As you can see, this is emphysema's images. These spaces are dilated. These alveolar walls are dilated. You can see there's thinning of the walls, and this isn't dilated this much normally. The restrictive lung disease, it may lead to decreased lung volumes, that is decreased FVC and decreased TLC, because there is problem with inspiration, right? You can't fill up the wall to its normal capacity, right? So FVC and TLC are basically different kinds of capacities of lung. So the capacity of lung is going to decrease to breathe in the air, right? So that is decreasing, so obviously FVC and TLC are going to decrease. The PFTs are normal or increased FEV1 to FVC ratio. Patient presents with short, shallow breaths to compensate the increased work of to increase the work of breathing by increasing the respiratory rate, because it has to overcome the elastic recoil, right, of the lung. So respiratory rate increase and via tidal volume decreases. Now the types of restrictive lung disease. Uh, First is altered respiratory mechanisms. So this is an extrapulmonary cause. So if it's an extrapulmonary cause, the DLC is going to be normal and AA gradient is also going to be normal. So yeah, we've discussed about it in the AA gradient section, that the issue can be in the inspired air. If the gradient is normal, the issue can be in the inspired air, that the FiO2 is less, or the issue can be in the patient but not in the respiratory system. It can be in the neuromuscular system or the neurological system, or opioid overuse, right? So yeah, this is the same extrapulmonary problems like respiratory muscle weakness, that is poliomyasthenia gravis and Guillain-Barré syndrome, and ALS, and chest wall abnormalities like scoliosis and severe obesity. Now the second type is, here the DLC on A gradient is normal, but in the second type, diffuse parenchymal lung disease, also called ILDs, it is it is a pulmonary problem. So DLCO is going to decrease and A gradient is going to increase, because there is going to be more oxygen in the alveolar walls, and it's not able to travel across the alveolar wall. And so on the other side, that is arterial side, the oxygen pressure is going to be low, so that increases the gradient. So which ILDs are there? There's pneumoconiosis, that is occupational RLDs, that is coal workers, silicosis, asbestosis. Then there's sarcoidosis, bilateral hilar lymphadenopathy. There's non-cagitating granulomas. There's ACE and calcium increase. So sarcoidosis is such an important topic for step 1. Like, you will see ton of questions for sarcoidosis, but luckily it's a very easy topic to understand, right? So there's just a few things that you have to keep in mind to answer the sarcoidosis questions, and you are good to go for all of those questions, right? And there's idiopathic pulmonary fibrosis, there's granulomatosis with polyangiitis, there's pulmonary Langerhans cell histiocytosis, hypersensitivity pneumonitis, drug toxicity like bleomycin, busulfan, amiodarone, methotrexate. Right? This bleomycin and amiodarone are important ones. Acute respiratory distress syndrome. Then there's radiation-induced lung injury that is associated with pro-inflammatory cytokine release. There is IL-1, 6, and TNF-alpha. It may be asymptomatic, but most common symptoms are dry cough and dyspnea and low-grade fever. Acute radiation pneumonitis develops within 3 to 12 weeks. There is exudative phase, and radiation fibrosis may develop after 6 to 12 months. So acutely pneumonitis develops at 3 to 12 weeks, but after 6 to 12 months, radiation fibrosis may develop. So the most important are the first two ones in ILDs. Right. Let's discuss about the idiopathic fibrosis. It's a progressive fibrotic lung disease of unknown etiology. It may involve multiple cycles of lung injury, inflammation, and fibrosis. It is associated with cigarette smoking, environmental pollutants, genetic defects, but most commonly it's counted as idiopathic, right? in most of the population. So findings are progressive dyspnea, fatigue, non-productive cough, crackles, clubbing, and there's clubbing here. One second, guys. Right, so imaging shows peripheral reticular opacities with traction bronchiectasis, honeycomb appearance of lung that is in advanced disease, and histological pattern shows usual interstitial pneumonia. Right, so yeah, clubbing is absent in COPD. Right, it's present in ILD. It is present in this interstitial lung disease. It can present in lung cancer, in lung abscess, and pulmonary TB. These four are the most common causes of clubbing. Okay, let me just write it down. ILD, lung cancer. Lung cancer is the most common cause of clubbing. The respiratory cause of, no, sorry, it's overall, I think the most common cause of clubbing is lung cancer. Then there's pulmonary TB and lung abscess as well. Now the keywords in ILD are this: progressive dyspnea and dry cough. Dry cough plus exertional dyspnea 95% of the time is ILD. Right? And yeah, there's honeycomb appearance of lung that is in the advanced disease, and there's also septal thickening. You will figure out honeycombing pattern in CT scan if you've shown one, because it's very typical of ILD. Right? And it looks like a net-like pattern on chest X-ray, and that is seen as honeycombing on CT scan. Also, on histological slides, there's going to be collagen, there's going to be fibroblast, and there's going to be inflammatory infiltrates. These all comprises of fibrosis, right? And the treatment is TGF beta inhibitors, PDGF inhibitors, VEGF inhibitors like perfenidone and nintedanib. Yeah, nintedanib is a new drug, but it's very costly. There's also perfenidone. Right, these are VEGF, vascular endothelial growth factor inhibitors. Then let's discuss hypersensitivity pneumonitis. So it's a mixed type 3 and type 4 hypersensitivity reaction to environmental antigens, often seen in farmers and bird fanciers. Acutely causes dyspnea, cough, chest tightness, fever, and headache. They are often self-limiting if stimulus is removed. So there will be history of a farmer or hay worker or bird working with birds in a zoo, or any kind of history. And it will be said in the question that if the stimulus was removed or the patient went on a holiday, the symptoms got improved. Right? So that is HB. Chronically leads to irreversible fibrosis with non-caseating granulomas, alveolar septal thickening, traction bronchiectasis, all the changes of pulmonary fibrosis. Right? Yeah, there's also chest tightness and fever, which isn't seen with any other kind of RLDs. Okay, sarcoidosis, that is characterized by immune-mediated widespread non-caseating granulomas. There's elevated serum ACE levels, anticholinesterase levels, and elevated CD4 to CD8 ratio. So CD4 is increased and CD8 is normal. In bronchoalveolar lavage fluid, more common in black females, often asymptomatic except for enlarged lymph nodes. Chest X-ray shows bilateral adenopathy and coarse reticular opacities. Like in this one, these are the opacities. Right? There is going to be bilateral adenopathy. CT of the chest better demonstrates the extensive hilar and mediastinal adenopathy. Associated with Bell's, ton of things, Bell's palsy, uveitis, granulomas that are non-caseating. This is the key word, that the granulomas are non-caseating. As you can see, there is no central clearing in this, unlike caseating granulomas. So this is going to be non-caseating, right? There's lupus pernio skin lesions on face resembling lupus. There's microscopic Schaumann and asteroid bodies. Interstitial fibrosis, RLD pattern, erythema nodosum, rheumatoid arthritis like arthropathy, hypercalcemia due to increased 1-alpha hydroxylase mediated vitamin D activation in macrophages, associated with granulomas that are non-caseating epithelioid containing microscopic Schaumanns and asteroid bodies. Rheumatoid arthritis like arthropathy, increased calcium, ocular uveitis, interstitial fibrosis, vitamin D activation, right, due to 1-alpha hydroxylase in macrophages. This is very important. It why is there hypercalcemia in sarcoidosis. So there's going to be macrophages here, right, because it's a non-caseating granuloma. And macrophages have increased 1-alpha hydroxylase activity. And if you remember the vitamin D pathway, the activation of vitamin D that we'll discuss in the next endocrine system, I'm going to upload the endocrinology next. So we'll see in that that vitamin D's pathway includes activation by 1-alpha hydroxylase. So if macrophages are producing more 1-alpha hydroxylase, or if the activity is increased in macrophages, there's going to be increased activation of vitamin D and increased calcium. Right? The skin changes. There's lupus pernio, erythema nodosum. Right? If you want to remember the mnemonic, that's all right. But I haven't, because there are a ton of things that can go with sarcoidosis. All of them are, pretty much resembles or every other autoimmune disease there is. And sarcoidosis is very easy to diagnose. Sometimes where I work, there was a male patient, actually, male Indian patient that was diagnosed with sarcoidosis. He had no symptoms, none of these symptoms, right? And that patient came in for chest pain and was later diagnosed with it was an ACS patient. But when the chest X-ray was done, there was bilateral adenopathy, and from that he was diagnosed sarcoidosis. And he was a male. Like male to female ratio of sarcoidosis is like 1:7. It's that rare in male patients. But yeah, I was lucky enough to see that patient. It might not be very lucky for that patient, but yeah, I was lucky. So yeah, it's very easy to diagnose sarcoidosis even on the steps. You just have to look out for bilateral hilar adenopathy and the non-caseating granulomas. This is just the two things that you have to keep in mind to diagnose sarcoidosis. Yeah. And everything else will fall in place by itself. The inhalation injury and sequel complication of inhalation of noxious stimuli, that is smoke, it caused by heat particulates that are less than 1 micrometer diameter, or irritants like NH3. There is ammonia gas, right? Yeah. So it causes chemical tracheobronchitis, edema, pneumonia, and ARDS. Many patients present secondary to burns, carbon monoxide inhalation, cyanide poisoning, or arsenic poisoning. And it causes singed nasal hair, that is burnt nasal hairs, and soot in oropharynx, common on examination. And bronchoscopy shows severe edema, congestion of bronchus, and deposition. That is at 18 hours after inhalational injury, and the resolution after 11 days. And so, yeah, so it is caused by mostly smoke or carbon monoxide, cyanide poisoning, arsenic poisoning, burns, ammonia inhalation, everything. Right? And it's basically just an inflammation. So everything you see in inflammation is going to be there, like edema, redness, congestion. There's also going to be soot if it is a burns patient. There's going to be singed nasal hair, right? Pneumoconiosis. So there are 4 kinds of pneumoconiosis that are important here: asbestosis, silicosis, berylliosis, and coal workers pneumonia, out of which asbestosis and silicosis are the most important ones. Asbestosis is from the roof, was common in insulation, but affects the base. So asbestos is found in the roof, but it affects the base. And silica, coal, and berries are from the base, that is, it is found in the earth, but it affects the roof, which is upper lobes. Right? And also you can remember it that way: if A comes first in the alphabet and S comes later down in the alphabet, whichever letter comes first in the alphabet, it affects lower lobe. It is opposite here too. And S comes down the alphabet, but it affects the upper lobes, that is asbestosis and silicosis. Now, asbestos related diseases. Asbestos causes asbestosis, right? That's pretty easy to remember. And it causes pulmonary fibrosis. It can cause pleural disease, malignancies. It is associated with shipbuilding, roofing, plumbing, and it is ivory white, calcified, supradiaphragmatic, and pleural plaques are pathognomic. So risk of bronchogenic carcinoma is more than risk of mesothelioma. We all just remember that mesothelioma is very specific with asbestosis. That is right, but asbestosis most commonly causes bronchogenic carcinoma. Mesothelioma is very rare, right? But it is specific to asbestos-related diseases. And there's increased risk of Kaplan syndrome as well. Kaplan syndrome is rheumatoid arthritis and pneumoconiosis with intrapulmonary nodes, right? Rheumatoid arthritis and pneumoconiosis with intrapulmonary nodes. And it affects lower lobes. Yeah, that we talked about. Asbestosis affects the lower lobes. And asbestos, that is ferruginous bodies, are golden brown fusiform rods resembling dumbbells. Here it is. It is somewhat dumbbell shaped. And it is found in alveolar sputum sample visualized using Persian Persian blue stain and often obtained by bronchoalveolar lavage. Increased risk of pleural effusions. Right, so there is increased risk of pleural effusions as well. Then it can cause bronchogenic carcinoma too, right? And pneumoconiosis, as we know, that is restrictive type of lung disease. Right. So that goes for all of the pneumoconiosis. So second is berylliosis. Berylliosis, it is associated with exposure to beryllium in aerospace and manufacturing industries. It's a very rare disease. Even the pulmonologists may have seen a very few cases, if they have, in their lifetime. And granulomatous non-caseating, it is granulomatous and it is non-caseating granuloma on histology, and therefore occasionally responsive to glucocorticoids. There is increased risk of cancer and core pulmonary, and it affects the upper lobes. So it is found in earth, but it affects the upper lobes. Coal workers pneumoconiosis, it's prolonged coal dust exposure. So the macrophages get laden with carbon, and it causes inflammation and fibrosis. It is also called black lung disease. So there's increased risk of Kaplan syndrome as well. So what is Kaplan syndrome again? It is rheumatoid arthritis pneumoconiosis with intrapulmonary nodules. It affects the upper lobes. Small rounded nodular opacities are seen on imaging. And what is anthracosis? It is asymptomatic condition found in many urban dwellers exposed to sooty air. And the last one is silicosis. It is associated with sandblasting, foundries and mines. Macrophages respond to silica and release the fibrogenic factors, leading to fibrosis. It is thought that silica may disrupt phagolysosome and impair macrophages, increasing susceptibility to TB. It is thought that silica may disrupt phagolysosomes and impairs the macrophages. So mostly the patients with silicosis presents with TB, right? And even in the areas like deserted areas or areas where there's stone pelting done the most, like where I live, there are so many stone works and stone crafts going on because of the kind of land there is in the area I live. So there too, the patients in the 1980s and 1990s, when there was a spike in tuberculosis patients. So in this region where I live, in Gujarat, so there was increased number of tuberculosis patients through so there were increased number of tuberculosis patients, and the reason behind that was given that the stone pelting and stone crafts work is much more prevalent in this area, right? So that made the people susceptible to tuberculosis. Okay. Increased risk of cancer, core pulmonale and Kaplan syndrome. It affects upper lobes, eggshell calcification of hilar lymph nodes on chest X-ray, and the eggshell calcification of hilar lymph nodes. Right. It would be unilateral, right? In sarcoidosis, we saw the hilar adenopathy, but that will be bilateral, right? And there's also bare fringent silica particles plus dense collagenous nodules. Plus dust laden macrophages. dust because of the sandblasting and mines. Right, the pleural plaques diagram is given here. These are the pleural plaques, and there are, you will see 2 or 3 questions that give the same kind of similar images of pleural plaques, and you have to diagnose asbestosis from these pictures, right? And the pleural plaques will be seen something like this on the x-ray, right? And this is dumbbell shape. This is also very important to remember. So asbestosis has so many questions in the Uworld, right? So it's a pretty important topic. And also the NBMEs want to confuse you by giving options of both bronchogenic carcinoma and mesothelioma, and the question will be something like which is the most commonly caused cancer because of asbestosis or something like that. So you have to be aware that it is bronchogenic carcinoma that is more common. The mesothelioma isn't very common, but it's just specific to asbestosis. Right, and what is this? This is berylliosis. So there's no central clearing as such. So this can't be caseating, right? So it is non-caseating granuloma. The last topic is mesothelioma, the malignancy of the pleura associated with asbestosis. It may result in hemorrhagic pleural effusion, that is exudative, and pleural thickening. Is caused due to asbestosis, may result in hemorrhagic pleural effusion. So pleural effusion is mostly clear, right? And if it is bloody or something like that, malignancy is suspected. The same goes with pericardial effusion. If the pericardial fluid the color of the pericardial fluid is clear, but if the pericardial fluid comes out brown or reddish in color, malignancy or tuberculosis is suspected. Right? Histology may show Samama bodies. Electron microscope may show polygonal tumor cells with microvilli, desmosomes, and tonofilaments. Calretinine and cytokeratin is positive in almost all mesotheliomas and negative in most carcinomas. So tobacco smoking is not a risk factor for mesothelioma. And this calretinine and cytokeratin, they are specific for mesothelioma. Acute respiratory distress syndrome, ARDS, that is it is because of the alveolar insult, which causes release of pro-inflammatory cytokines, neutrophil recruitment, activation, release of toxic mediators, that is ROS, proteases, etc., and capillary endothelial damage and increased vessel permeability. So these 2 things are the most important, that there is capillary endothelial damage and increased vessel permeability. There's leakage of protein-rich fluid into the alveoli, formation of intraalveolar hyaline membranes, there is arrow in A. So this pink material that is around the border of the alveoli, around the border of the alveolar wall, is the hyaline membrane. And formation of intraalveolar hyaline membrane and non-cardiogenic pulmonary edema. It is non-cardiogenic because it's not of cardiac cause. And so there is normal PCWP, and which is pulmonary capillary wedge pressure, and that also means that the left atrial pressure is also normal. So there's going to be decreased compliance because now it is going to be very difficult to fill the lungs with the air, as there is already fluid in the alveolar spaces. And there's going to be VQ mismatch, and VQ mismatch is because of the ventilation has decreased, and there's going to be hypoxic vasoconstriction. And as there's vasoconstriction, there's going to be increased hypertension in those vessels. As it is in the pulmonary vessels, it is going to cause pulmonary vascular resistance increase and pulmonary hypertension. And loss of surfactant also contributes to alveolar collapse. Right, so if this is the alveoli, what the inflammatory cytokines like neutrophils and toxic mediators like reactive oxygen species and protease do is they make holes in the alveolar membranes. Right, so the surrounding capillaries, the fluid from the surrounding capillaries enter the alveoli. Right, so there's increase in vessel permeability too. Right, there's increase in vessel permeability, and there's also epithelial damage, endothelial capillary endothelial damage, which is going to form easy excess of fluid into the alveoli. Right, it's not very deep, it's very easy to understand. Okay, what are the causes of sepsis? Yeah, one more thing, the compliance is decreasing, right? So to make things simple, whole of the ARDS is going to be like RLD. Right. So in restrictive lung disease too, the compliance is decreasing. Here too, compliance decreases. So the consequences will be like that of an ARDS. There is going to be inspiratory problem. Right. The causes of ARDS are sepsis, that is most common. Then there's aspiration pneumonia, trauma, and pancreatitis. Diagnosis of exclusion with the following criteria, that is ARDS, abnormal chest X-ray, that is bilateral lung opacities, and these opacities are going to be diffuse, like it is throughout the lung. Then there's respiratory failure within 1 week of alveolar insult. There's decreased PaO2 to FiO2 ratio. Ratio becomes less than 300. Hypoxemia due to increased intrapulmonary shunting and diffusion abnormalities. Right, so obviously the PaO2 is going to decrease, right, because the oxygen is not reaching the alveolar spaces properly because of the presence of fluid in there. And hypoxemia occurs because of the intrapulmonary shunting, because the blood coming in from the heart through the pulmonary arteries into the not into the but surrounds the alveoli and goes back through pulmonary vein into the left atrium. So now, as there is, if this is the pulmonary artery and this is the pulmonary vein, normally the carbon dioxide gets exhaled here and oxygen gets inhaled here, and there's oxygenated blood in pulmonary vein. But now, as there's fluid in there, the diffusion isn't occurring, right? So the blood will go back deoxygenated as such, right? So it's kind of like this was coming from the right heart and this is going to the left heart. So it is like a right to left shunt, right? And from left heart it enters the body. So now the deoxygenated blood has entered the body and is also called hypoxemia. Hypoxemia is just decreased oxygen in the blood, right? And hypoxia was decreased oxygen delivery to the tissues. And symptoms of respiratory failure are not due to heart failure or fluid overload. Then only we can diagnose ARDS if there's no heart failure or there's no cardiac cause, right? Otherwise, it will be called cardiogenic pulmonary edema. What is the consequence? What is the consequences of ARDS? So first of all, there's going to be impaired gas exchange rate because there is presence of fluid in the alveoli. Then there's going to be decreased compliance because there's again fluid in the lungs. It makes the lungs more stiff. It makes the lungs more heavier. So it makes the lung more stiff. It makes the lung more heavier. So that is always going to be difficult to fill those lungs, right? And eventually there's going to be pulmonary hypertension because, as we talked about, the ventilation is decreasing. It is going to cause hypoxia that results in hypoxic vasoconstriction, and whenever there's vasoconstriction, there's going to be hypertension. And the management is treating the underlying cause, mostly treating the sepsis, and mechanical ventilation may be needed with decreased tidal volume and increased PEEP that keeps the alveoli open during expiration. Right. So normally, as there is reduced surfactant in the alveoli in ARDS, the alveoli tend to collapse during expiration. Right. So what PEEP does is it gives air even during expiration. Right. So the alveoli are not going to collapse even during expiration. Right. There's always going to be some pressure of air going into the alveoli, stopping it from collapsing. Now, the sleep apnea. So, sleep apnea, it is repeated cessation of breathing for more than 10 seconds during sleep, and that causes disrupted sleep, and daytime disrupted sleep causes daytime somnolence, and diagnosis is confirmed by sleep study. Right. Nocturnal hypoxia causes systemic and pulmonary hypertension, and it causes arrhythmia, that is atrial fibrillation and flutter, and it can cause sudden death too. And due to hypoxia, there's going to be erythropoietin release, and which is going to increase erythropoiesis. So there are different kinds of sleep apnea. Yeah. The first is obstructive sleep apnea. So that is because of respiratory effort against airway obstruction. Usually the patients that have obstructive sleep apnea, so they have increased oropharyngeal mass and pharyngeal mass that obstructs the airway during their sleep. Not throughout the sleep, but people who tend to sleep in supine positions for a longer hours, mostly they are under the risk of getting their airways obstructed by the pharyngeal mass, right? Not mass in the sense, but their pharynx itself is a little bit boggy, somewhat boggy, right? So that can fall back and close the airways. Right. Just a second, guys. Yeah, so it's respiratory effort against airway obstruction. So PaO2 is usually normal during the day. It's just supine sleeping problem, right? So PaO2 is going to be normal during the day, and is associated with obesity, loud snoring, and daytime sleepiness. This is usually caused by excess parapharyngeal and oropharyngeal tissue in adults and adenotonsillar hypertrophy in children. Okay. Excess parapharyngeal and oropharyngeal tissues. So their pharynx, oropharynx and parapharynx are a little bit boggier than other people. And treatment is weight loss, CPAP, and dental devices, hypoglossal nerve stimulation. This is important. There are questions asked about this. And this upper airway surgery. Right. So yeah, it can also cause hypertension, pulmonary hypertension, as well as systemic hypertension, as it is mentioned here. And one of the thing to remember is the acid base balance is normal. Okay, we'll discuss later on why I wrote this here. Okay, so second is central sleep apnea. It is impaired respiratory effort due to CNS injury or toxicity. Right, there is nothing going on with obesity or supine sleeping or anything like that, but it is a CNS problem. So there's impaired respiratory effort due to CNS injury, toxicity, congestive heart failure, or opioids. May be associated with Kind-Stokes respiration. There's oscillations between apnea and hyperapnea. So the respiratory graph is something like this. Then this is normal breathing. Then there's apnea episode, again normal breathing. Then there's hyperapnea episode, something like that. Yeah. So treatment is positive airway pressure for that. And there's obesity hypoventilation syndrome. It's also called Pickwickian syndrome, and it's in patients whose BMIs are more than 30, and they tend to hypoventilate. And whenever there's hypoventilation, there's going to be buildup of carbon dioxide inside the blood, so that is increasing PaCO2 during waking hours, that is retention. So decreased PaO2 and increased PaCO2 during sleep. Right. So during sleep, PaO2 is going to decrease, and treatment is same: weight loss and positive airway pressure. Yeah, so this is the difference between OHS and OSA, that in OHS the PaCO2 is increased during sleep, but in OSA the PaCO2 is normal during sleep, right? The AA gradient is going to be normal. Still the AA gradient is normal, even though PaCO2 increase and PaO2 decreases. There is no problem with alveolar wall function, right? And then there's also narcolepsy that you should know about. So narcolepsy is daytime sleep attacks. There's poor REM sleep, that is rapid eye movement stage of sleep. Plus there also can be hallucinations and sleep paralysis. And severe obesity may, even if it's not causing OSA or OHS, it may cause a restrictive type of PFTs, right? So that is not very pathological, but obese people tend to have restrictive type of PFTs. And this is very important topic for the steps. Okay. The pulmonary hypertension. So elevated mean pulmonary artery pressure, that is more than 20 mmHg at rest, and it results in arteriosclerosis, medial hypertrophy, intimal fibrosis of pulmonary arteries, and plexiform lesions. Okay, arteriosclerosis, medial hypertrophy, and fibrosis of pulmonary arteries. Increased pulmonary vascular resistance causes increased right ventricular pressure because it has to push against a stiff pulmonary artery vessel, and it can cause right ventricular hypertrophy and RV failure as well. So which are the etiologies? So first is pulmonary arterial hypertension. It's often idiopathic. It most commonly affects females, young females, and it is heritable PH can be due to inactivating mutation in BMPR2 gene. Normally inhibits vascular smooth muscle proliferation. Right, it inhibits the vascular smooth muscle proliferation. So if there is an inactivating mutation, it's not going to inhibit the smooth muscle proliferation, and there's going to be thicker vessels, and the thicker vessels always produce more tension, that is hypertension. And has poor prognosis. Pulmonary vasculature endothelial dysfunction results in increased vasoconstrictors, that is endothelin, and decreased vasodilators, that is nitric oxide and prostacyclins. Right, so the treatments revolves around these vasoconstrictors and vasodilators. We have to decrease either the vasoconstrictors, or we have to increase the vasodilators, right, to treat pulmonary hypertension. So other causes includes drug like amphetamines and cocaine. Like we know that cocaine causes vasoconstriction, right? Then there's CTDs, HIV infections, portal hypertension, congenital heart disease, and schistosomiasis. PHTN can also develop due to left heart diseases like systolic and diastolic dysfunction and valvular disease. Lung diseases or hypoxia may also cause hypertension because there's going to be hypoxic vasoconstriction, right? So destruction of lung parenchyma, example in COPD, lung inflammation and fibrosis like in ILD, and hypoxemic vasoconstriction like in OSA, and people living in high altitude. Right, people living in high altitude that we discussed about, they tend to be more hypoxic when they just move to high altitudes, and everything every symptom there is in patients living in high altitude is due to that hypoxia. So due to that hypoxia, there was RVH and right heart failure, there was increase in 2,3 BPG, and there was increased O2 loading in the tissues, right? All sorts of things were there, and hypoxia was also causing acidosis, I think. Right, so it was causing hyperventilation, and hyperventilation was causing decreased carbon dioxide, that was causing respiratory alkalosis. Right. And due to respiratory alkalosis, the bicarbonate was excreted in kidneys. Right. Chronic thromboembolic, that is recurrent microthrombi, that decreases the cross-sectional area of pulmonary vascular bed. So that is not important at all. And it can also be multifactorial, where causes include hematologic, systemic metabolic disorders, along with compression of the pulmonary vasculature by a tumor. Now, physical findings in selected lung diseases. In pleural effusion, the breath sounds decrease, the percussion is dull, fremitus decreases, and tracheal deviation is none if small and away from the side if large. Right. Right. And then there's atelectasis. It's same as pleural effusion, but the tracheal deviation can be towards the side of lesion because it stretches the parenchyma towards itself. Right. And what is fremitus? If you've done examination of patients in the ward, like we used to test for tactile vocal fremitus, right? We used to put our medial side of the hand on the intercostal space, each intercostal space, and tell the patients to say 1 2 3 or anything like that, and we used to feel for the vibrations in the intercostal space. But as there's fluid in the pleural space, it is going to insulate those vibrations down. Right. Then there's simple pneumothorax. Instead of fluid, there is going to be air in the pleural space that is going to work same in insulating the sounds down for us, just like pleural effusion. So the breath sounds are going to be decreased, fremitus is decreased, but as it is just air in the pleural space, and there's also air in the alveoli, so the percussion is going to be hyper resonant. Right. So fluid can dampen the percussion note of the air coming in from alveolar space, but if there's air in the pleural space itself, it is going to convey the percussion note more powerfully, or in the other words, hyper resonantly. Right. So tracheal deviation is none if it's a simple pneumothorax, but if it's a tension pneumothorax, it is away from the side of lesion. Because the air pushes the trachea away from itself. Right. Now the consolidation, that is lobar pneumonia and pulmonary edema. Right. So the breath sounds heard are bronchial breath sounds, that is late inspiratory crackles, egophony or whispered pectoriloquy. Okay, that is okay, but it's not very important for us to remember at this stage. But yeah, the percussion is also going to be dull as there's fluid. Consolidation is a kind of fluid, right? The exudates are there in the alveolar space, so the percussion is going to be dull, but the fremitus is going to be high, because now you'll wonder why the fremitus was decreased in pleural effusion. So in effusion, let's first talk about in effusion. So if this is a pleura, I've exaggerated it a little bit. So in pleural effusion, there's going to be fluid here, and there's going to be air. There's going to be air here, right in the lungs. So during fremitus, vibrations arise from this air and wants to travel outwards. But what the fluid of the pleural effusion do is it dampens the vibrations, right? So the fremitus is going to be decreased. Right. On the other hand, in consolidation, there's nothing in the pleural space, right? There's just air, right? It's non-specific. We don't even need to show it here for our diagram. So now in consolidation, what's there? There is going to be fluid in the lung itself. Here there was air, but here as there's consolidation, there's going to be exudate and there's going to be fluid in the alveolar space. Now if you know the basic physics, fluid transmits vibrations faster and uh, just faster than the air and more powerfully than the air, right? So on the so the vibrations arise from here, right? Vibrations arise from the alveolar space, and as it has fluid inside of the alveolar space, it is going to transmit the vibrations way more powerfully than of air. So as a result, the fremitus is going to increase, right? And there's going to be no tracheal deviation, right? If there was going to be fluid here, it could have dampened the fremitus down, but as there is no pleural effusion, the pleural space is cleared, we can hear the fremitus arising from the fluid very comfortably, right? And yeah, also there's one more thing, that the fremitus will be increased just unilaterally in pneumonia, right? Because it is a lobar pneumonia, just one of the lobes of one of the lungs is going to be affected, but it can be bilateral in cases of heart failure and pulmonary edema, because there is no differentiation in heart failure or pulmonary edema. Whole of the lung is affected in the same way or at the same rate, right? So the fremitus is going to be high bilaterally. Now the digital clubbing, increased angle between the nail bed and the nail plate, more than 180 degrees. Pathophysiology not well understood. In patients with intrapulmonary shunt, platelets, megakaryocytes become lodged in distal vasculature, that causes a local release of PDGF, and VEGF can be hereditary or acquired. Causes include respiratory disease like IPF, cystic fibrosis, bronchiectasis, and lung cancer, all those that we mentioned earlier, right? Cardiovascular diseases like cyanotic congenital heart disease, infections like lung abscess that we mentioned too, TB that we mentioned too, and others like IBD, not typically associated with COPD or asthma, right? Atelectasis, so there is alveolar collapse. As you can see in the diagram, the right upper lobe collapse against the mediastinum, right? So this little portion has collapsed, so that is why it looks like opacified part, right? If it had air, it would look something like this, right? Now there are multiple causes. So first is obstructive airway obstruction, prevents new air from reaching the distal airways, and old air is resorbed into the blood system. So there is foreign body and mucus plug tumors. So if this is the obstruction, it is going to affect this part, right? And all the air that is remaining in these lungs will get resorbed back into the blood, and new air is not entering, so it will get opacified or collapsed, so that will look like this. Second is compressive, that is external compression on lung decreases lung volumes, like space occupying lesions, pleural effusions. So it's something like obstructive too, right? So but rather than pure obstruction, it is of compressive nature, like of space occupying lesions, that is lung tumor or pleural effusion or something like that. Third is contraction, that is scarring of lung parenchyma that distorts alveoli, like in sarcoidosis. So as you can see here, there is scarring. So whenever there is scarring, this is the alveoli and this is the surrounding parenchyma. So what happens in scarring is the lung parenchyma gets stretched due to the fibrosis. So alveoli might get collapsed, right, because of all the stretching. So see, this is the collapsed alveoli. Yeah. So collapsing occurs this way in cases of fibrosis. Now there's the fourth point is adhesive. So adhesive can be due to the lack of surfactant, that is NRDS in premature babies. So yeah, if there's no surfactant, so what was the role of surfactant again? The role of surfactant was to prevent the alveoli from collapsing. So now as there's no surfactant, there is nothing preventing the alveoli from getting collapsed, right? So in NRDS, that is premature babies, so lungs mature by 34 weeks of gestation, right? So if the baby is premature, there are chances that there's going to be less surfactant than normal babies, right? So the premature babies are at the verge of developing NRDS. Now the pleural effusion. Pleural effusion is, I think, one of the most important topics of the respiratory system, right? So pleural effusions is excess accumulation of fluid between the pleural layers, and that restricted lung expansion during inspiration. Right, it's very obvious. If we are compressing the lung with some kind of fluid, we are not going to let the lungs expand. So if the lungs can't expand, they are not going to inspire properly. And it can be treated with thoracocentesis. We just have to remove out this fluid. To remove and reduce fluid, based on the Light's criteria, fluid is consistent with an exudate if pleural fluid protein by serum protein is more than 0.5, pleural fluid LDH by serum LDH is more than 0.6, or pleural fluid LDH is more than 2/3 upper limit of the normal serum LDH. Right, so basically it is of exudative nature if it has high protein, high LDH. Okay, just two things: if it has high protein and high LDH. So see, serum isn't throughout the body, right? Throughout the body there is serum, so there's obviously going to be more protein and more LDH in the serum, and the pleural fluid consists of very less part, that is just the pleural cavity, right? Even if the whole pleural cavity is being filled with the pleural fluid, it is going to be of very less quantity compared to the whole of the body's serum. So there's obviously going to be more protein and LDH in the serum, but whenever the pleural fluid is of exudative nature, there's going to be increased protein in the pleural fluid, and there is going to be more LDH in the pleural fluid, but never more than the whole serum protein and whole serum LDH, right? So a mere increase in protein and LDH in pleural fluid is going to increase the ratio of pleural fluid protein and pleural fluid LDH to that of serum protein and serum LDH. Right, as you can see, the pleural fluid protein and serum protein ratio increases more than 0.5. It does not increases more than 1 ever, right? Because if it increases more than 1, then what does it mean? That pleural fluid has more protein than the whole serum protein, right? So that is impossible, and so it is just more than 0.5, right? and pleural fluid LDH by serum LDH is more than 0.6. So that also doesn't cross 1, right? Because then it would mean that pleural fluid has more LDH than the whole serum, and that is again impossible. Or pleural fluid LDH is more than 2/3 upper limit of the normal LDH, right? So if imagine LDH is 100 in serum, so pleural fluid might have pleural fluid might have something around 65%, I think 65 or 67%, right? So the LDH in pleural fluid would be around 65 to 67. In serum it would be around 100. So again you can see that it will never reach the amount of serum LDH, right? And this was we talked about the ratio, that is 0.5 for proteins and 0.6 for LDH. But what about the actual values? So in questions time there are actual values of protein given of the body and of the pleural fluid. You should know that what are the normal values, right? So the total protein in serum is 6 to 7.8 gram per deciliter. And if the pleural fluid protein is more than becomes more than 4 gram per deciliter, it is going to be exudative, because 4 by 6 is more than 0.5, right? So that is going to be exudate. Now the causes of exudate. So exudate is a cloudy fluid that is cellular, and transudate is a clear fluid. It's just like water, right? But exudate is water plus proteins plus LDH, so that the proteins make it a little bit cloudy, and it can be due to infection, pneumonia and tuberculosis, malignancy, connective tissue diseases, lymphatic chylothorax, trauma, and often requires drainage due to increased risk of infection. And transudate, that is clear fluid, and it is hypocellular due to increased hydrostatic pressure in heart failure and sodium retention. So that is just increased hydrostatic pressure means the fluid is being pushed out of the blood vessels into the pleural cavity, right? Wherever there is more hydrostatic pressure, it is going to apply pressure towards the opposite side. It is going to try to push the fluid out of that in high hydrostatic pressure. So right, there is increased hydrostatic pressure here, so it is going to push the fluid out into the pleural cavity, right? And decreased oncotic pressure, that is in nephrotic syndrome and cirrhosis due to protein loss, right? Decreased oncotic pressure is always due to protein loss. And if there is decreased oncotic pressure here, it is not going to hold on to the water, so water will get pushed away into the pleural cavity. And what is the mechanism behind exudate? So we learned that it is mostly due to the infections, right? So infections secrete inflammatory cytokines, right? And inflammatory cytokines are going to increase the vascular permeability, and it is also going to cause some endothelial damage, that is going to let the proteins and the fluid out of the blood vessel into the pleural cavity, right? And yeah, this lymphatic chylothorax, it is mostly due to malignancy, So malignancy or that tumor, malignant tumor may block the lymphatic flow. So although it is exudative, but it will be of milky color rather than serosanguinous. Right, if the exudate is due to the infective pathology, the pleural fluid might be serosanguinous, but if it's due to tumor and that tumor has blocked lymphatic channels, it is going to be of milky color. Also, with the adenocarcinoma of lung, there's going to be effusion, pleural effusion, but it would also contain mucin as well as RBCs. And if it's going to be lymphoma, it is going to cause chylothorax as well, just like the mechanism we talked about. Yeah, that's pretty much it. And yeah, one more thing, that if fibrosis takes place in the setting of pleural effusion, it is going to form empyema, right? So what is empyema? So empyema is pus plus fibrosis, and it is not very free flowing fluid like the pleural effusion, right? And pleural effusion sets in the uh, most dependent part, that is the posterior segment of the lower lobes, but empyema is not that free flowing, so because it is getting fibrosed, right? So they will not change positions easily with person's position, right? And sometimes to draining empyema is hard to, right? Because the fluid is now very thick, so to drain empyema we have to liquefy it with streptokinase sometimes, right? So it can be liquefied to drain with streptokinase, that is TPA activator. So it's a plasminogen activator that is going to form plasmin, and that is going to cleave fibrinogen into fibrins, right? Now pneumothorax. So there is accumulation of air in the pleural space. It can cause dyspnea and uneven chest expansion. There's chest pain, decreased tactile fremitus. Right. There's hyperresonance. There's diminished breath sounds, all on the affected side. Why is there decreased tactile fremitus? Because there's air in the pleural space, so that is going to dampen the vibrations coming in from the alveolar space, right? If there was fluid in the pleural space, it is also going to dampen the tactile fremitus. If there is fluid in alveolar spaces itself, that is consolidation or pulmonary edema or something like that, it is going to enhance the tactile fremitus, right? Because vibrations travel faster through fluids than through air, right? So any pathology in pleural space, it is going to dampen the tactile fremitus as well as the just tactile fremitus. It is not going to dampen the percussion note, right? So there's hyper resonance percussion note because there is air in alveolar space, there is air in pleural space too. So the percussion note will be hyper resonant, right? It would be like playing the drums. So the breath sounds will be diminished as well. And the first is primary spontaneous pneumothorax due to rupture of apical subpleural bleb or cyst, occurs most frequently in tall, thin young males who are smokers, right? Just like we talked about the pneumomediastinum, spontaneous pneumomediastinum, it is occurring in tall, thin young males associated with tobacco smoking. Secondary spontaneous pneumothorax is due to diseased lung, that is bulla and emphysema, Marfan syndrome, infections, mechanical ventilation with use of high pressures. So barotrauma. Right. Then third is traumatic pneumothorax caused by blunt rib fracture, penetrating gunshots, or iatrogenic, that is central line placement. Anything that can pierce the pleural cavity can cause traumatic pneumothorax. Like in blunt rib fracture, a fractured rib is very sharp. It can pierce the pleura. Penetrating gunshot can pierce pleura. Iatrogenic central line placement can pierce the pleura mostly if it's a subclavian line placement, there is a risk of piercing the pleura. There's lung biopsy, barotrauma due to mechanical ventilation and trauma, all of those, right? Tension pneumothorax, now that is important. Primary spontaneous pneumothorax is important and tension pneumothorax is important. It can be from any of the above, but air enters pleural space but cannot exit, right? Increasing trapped air, tension pneumothorax. Trachea deviates from the affected side, may lead to increased intrathoracic pressure, mediastinal displacement, kinking of IVC because of the pressure, and kinking of IVC will decrease the venous return to the right heart, which will cause decreased cardiac output and obstructive shock. It is characterized by hypotension and tachycardia. There is going to be jugular venous distension because of kinking of IVC, and we are pressuring the IVC distally, right, towards the end of the IVC, right? So there is going to be distension above that. So it needs immediate needle decompression and chest tube placement. Right. I think there's that episode of Good Doctor. I think it's just the first scene of the Good Doctor where there was a kid that needed immediate needle decompression. Right. Was it pneumothorax or that kid needed tracheostomy? I don't remember exactly what was that, but you might have seen plenty of movies where the patient had tension pneumothorax and he needed immediate needle decompression and chest tube placement and all. Right, so why is tension pneumothorax more fatal than spontaneous pneumothorax? Because in tension pneumothorax, there's just one way. There's no exit. It's the air just enters and enters and enters the pleural space, and more air enters the pleural space, more pressure it is going to generate on the mediastinum and the trachea, right? So as you can see here, like what is the difference here and here? And here you can see that this lung is normal, it is air filled, but it is normal, so it has alveolar walls, respiratory bronchioles that can be seen with this thin lines, that is this thin opacities, right? This thin opacities are alveolar walls, respiratory bronchioles, basically the whole lung. But on this side is very, very clear, right? The lung can't be this much clear, this much transparent, right? So the only option is that there is no lung here, right? This space is open. The lung is just in this part. Everything here is empty, right? You can see the posterior ribs, anterior ribs, everything very precisely. So that is just because there is no lungs there. Why is there no lungs there? Because there is tension pneumothorax. Air is entering somewhere from here or somewhere from here, and that air has pushed the lungs to collapse itself. The lung has collapsed itself. It is also pushing the trachea towards the opposite side. It is also pushing the mediastinum towards the opposite side, right? Here you can see this is the air. It appears very dark on the CT scan, right? Yeah, that's just it. It's a very simple topic to understand. Right. There's going to be kinking of IVC, and there's going to be jugular venous distension. This is also important to remember. Also, I wanted to discuss about panic attacks, because in first aid respiratory system there's nothing given about panic attacks, but there are questions that are being asked about panic attacks from the respiratory system. So what exactly they are, we'll learn in the psychiatric section, but how it affects the respiratory system we'll see here. So we know that panic attacks patient have they start hyperventilating, right? If you have seen a panic attack patient, you are not going to forget it, that they tend to hyperventilate, right? So whenever there is hyperventilation, there is going to be more excretion of carbon dioxide, right? So PaCO2 is going to decrease. And now we know that high CO2 concentrations are more important to maintain cerebral blood flow than oxygen levels, right? Except in COPD, that we've discussed. Why there's except in COPD? Because there's always CO2 retention, there's always hypercapnia in COPD. So the brain's respiratory centers have stopped responding to higher concentration, like हाँ वो तो कार्बन डाइऑक्साइड तो ज़्यादा ही होगा ऐसे. So now the brain respiratory centers just respond to oxygen levels, right? So in COPD, brain respiratory centers just respond to hypoxia rather than hypercapnia. But in normal patients with panic attacks and not COPD, the hypocapnia is going to cause decreased cerebral blood flow, right? And decreased cerebral blood flow, if there is less blood being reached to the brain, we know that there's going to be dizziness and blurred vision. So that is why after some time panic attack patients may get dizzy or may get blurred visions. And the question stem may also give you this symptoms, that it might be a young female in 20 to 30s, right, that is having blurred visions, right? And also might be given that she has stressful lifestyle or going through something, some emotional trauma or anything like that, to give you an idea of panic attacks. But the straight diagnosis might not given, they might not give it away that easily that the patient is of panic attacks. So you have to diagnose panic attacks, and then you have to think about, yeah, the patient might be hyperventilating too. Or it can also be given in the question stem that the patient was hyperventilating when she presented to the ED. And if the patient is hyperventilating, be it of panic attack or any other normal person, the PaCO2 is always going to be low, and it is because of that PaCO2 the cerebral blood flow has decreased, and it is causing dizziness and blurred vision, all of those symptoms that are given in the question. Right, so this hypocapnia, decreasing the cerebral blood flow, right, so that is helpful in cerebral edema patients, right, because in cerebral edema, just a second guys. So in cerebral edema patients, there's edema in the brain, right? So what we have to do to prevent more edema being formed is we have to decrease the cerebral blood flow. So we tend to keep patients on hyperventilation. We hyperventilate the patients, because so that is going to decrease the PaCO2, and that is going to decrease the cerebral blood flow to decrease the edema. Right, so yeah, now we'll see about the pneumonia section. So the first is lobar pneumonia. The most common organisms are strep pneumo, then there's Legionella and Klebsiella. There's going to be intraalveolar exudate, consolidation, and may involve entire lobe or the whole lung. But mostly it involves just a single lobe. That is why it's called lobar pneumonia. Second is bronchopneumonia, that is caused by strep pneumo, Staph aureus, and H influenza, Haemophilus influenza, and Klebsiella. There is going to be acute inflammatory infiltrates from bronchioles into adjacent alveoli, and there is patchy distribution involving more than one lobe, because the inflammatory infiltrates arises from the bronchioles, right? So bronchioles can lead to several lobes at once, right? This can be one lobe, this can be second lobe, so the distribution is going to be patchy. As you can see here, there's inflammatory infiltrates, right? These all are inflammatory infiltrates. The third is interstitial or atypical pneumonia, that is caused by mycoplasma, chlamydophilia pneumonia, Chlamydophila psittaci, Legionella, Coxiella, Burnetii, and viruses like RSV, CMV, influenza, and adenovirus. And diffuse patchy inflammation, there's diffuse patchy inflammation, not just patchy or not just lobar, right, but it's diffuse, localized to interstitial areas at alveolar walls. Chest X-ray shows bilateral multifocal opacities, generally follows a more indolent course, that is walking pneumonia. So patient might not feel that worse, but upon reviewing the examinations and upon reviewing the chest X-ray, the condition appears more bad than the symptoms of the patients, right? You can see there is multiple opacities on both the sides of the lung, so that is bilateral. That is characteristic of interstitial pneumonia. The fourth is cryptogenic organizing pneumonia. The etiology is unknown. There's negative sputum and blood cultures. The cultures are negative and often responds to glucocorticoids but not to antibiotics. It was formerly called bronchiolitis obliterans organizing pneumonia, BOOP, and non-infectious pneumonia characterized by inflammation of bronchioles and surrounding structures. So it is not of non-infectious etiology, but it responds to glucocorticoids, but because there's just inflammation and not infection. Right. Then there's aspiration pneumonia. Aspiration of oropharyngeal or gastric contents may cause pulmonary infection. Risk factors are altered mental status, that is decreased cough, reflex or glottic closure, dysphagia, neurological disorders like stroke, invasive tubes, example nasogastric tubes. It presents days after aspiration event, independent lung segment, more common in right lower lobe if sitting up, and right upper lobe if lying down due to bronchial anatomy. There is posterior segment of the right upper lobe. Right. It can progress to abscesses too. And aspiration pneumonitis, it presents hours after aspiration event due to gastric acid mediated inflammation. Right. And presents with infiltrates in lower lobes and resolves with supportive treatment. Right, so there can be confusion between aspiration pneumonia and aspiration pneumonitis. So aspiration pneumonitis is only due to gastric acid contents. It is acid, right? So it is going to cause some damage to the lung parenchyma, and that is a quicker damage, right? So it will present just hours after the aspiration event. And aspiration pneumonia is due to mostly the oropharyngeal contents, right? The bacteria may travel with the aspirate from the oropharynx to the lungs, and that will cause the pneumonia. Right? So it can be due to oropharyngeal bacteria, and it is going to present days after aspiration. Pneumonitis presents hours after aspiration. As you can see in the bronchopneumonia, there's patchy distribution, so involving more than one lobe of the lung. Right. So you can see there are many patches of bronchopneumonia. Now, in pneumonia, in the setting of pneumonia, if we talk about VQ mismatch, so first of all, we know that V is going to decrease, right? Because there's hypoxia due to consolidation, and that is going to lead to vasoconstriction. But there's also infection, right, with pneumonia. And as we know, infection may lead to secretion of cytokines. And cytokines, as features of inflammation, is going to cause vasodilation and endothelial damage. So let's just focus on vasodilation for this thing. There's going to be vasodilation. So if there's vasodilation of the pulmonary capillaries, the perfusion is going to increase, right? And the perfusion is going to increase throughout the lungs, right? So now the previously hypoventilated alveoli that had vasoconstriction, right? So the alveoli which were hypoventilated, they weren't given much blood to deal with. There was vasoconstriction in the pulmonary capillaries surrounding those hypoventilated alveoli. Right. But with infection, there's going to be vasodilation throughout the lungs. So even the blood capillaries surrounding the hypoventilated alveoli that were previously vasoconstricted will be now vasodilated. So there is going to be perfusion to hypoventilated alveoli as well. And so Q is being increased and V is being decreased. So there's going to be even more VQ mismatch. Than there was just because of the hypoxia. Here only V was decreasing and Q was normal. So VQ mismatch was there, but it was just a little bit. But with infection, the Q is increasing too. Right? So V is decreasing, Q is increasing. So VQ mismatch is going to increase. Now, so for the treatment part, we just have to reduce the cytokines, right? So that the vasodilation decreases and the vessels go back to being vasoconstricted as they were for hypoxia. Right. So we induce vasoconstriction by decreasing the cytokines. And if vasoconstriction is being increased, so VQ will get normal slowly, and PaO2 and O2 saturation is going to increase, right? But decreasing the cytokines isn't going to help us with decreasing the exudate that is already there in the alveoli, right? We are just providing vasoconstriction to the pulmonary capillaries surrounding those hypoventilated alveoli. So PaO2 and O2 saturation is going to increase earlier in the course of management than the clearance of consolidation, right? So the patient might feel better earlier in the course of management, but upon seeing the chest x-ray again, there still might be consolidation in the alveoli. But the patient might feel better than earlier. Yeah. And two more things. First is Loeffler syndrome. What is Loeffler syndrome? It is eosinophilic pneumonitis caused by Ascaris sum, and it is received from pigs. Pigs are the carrier for Ascaris sum. This is important. There is a question in Uworld that asks us that does the consolidation clears off first, or the O2 saturation and PaO2 gets normal first? So it is the PaO2 and SaO2 that is going to improve earlier than the consolidation. Also, there's nothing given in first aid about the acute exacerbation of COPD. COPD patients present to the hospital all the time with acute exacerbation, right? And so the most common causes for acute exacerbations are in viruses, it is rhinovirus, RSV, and influenza. And in bacteria, it is H. influenza, Haemophilus influenza, strep pneumo, and Moraxella catarrhalis. Out of which strep pneumo and H. influenza are common ones. Now the natural history of lobar pneumonia. So there are 4 stages in lobar pneumonia, that is congestion, red hepatization, grey hepatization, and resolution. So the first stage, congestion, is when bacteria arrives at the site, right? So finding it is in the first 2 days. The findings are red, purple, partial consolidation of parenchyma, and thus exudate with mostly bacteria. So the WBCs, the leukocytes, macrophages, all that haven't arrived yet. It's just the bacteria that is being in the alveoli for the first 2 days. So now in the 3rd and 4th days, there is going to be red hepatization. Hepatization is because the consistency of the lung changes to that of a liver, right? So liver is red, orange, grayish type, right? So the red color and the gray color of the lungs is being similar to that of the liver. There's going to be red brown consolidation. There's going to be exudate with now fibrins, bacteria, RBCs, and WBCs have start arriving at the site. And the stage is reversible if treatment is given. Right? All of those stages aren't seen clinically because treatment of pneumonia is started as soon as the diagnosis is made. So the patient doesn't even go to the 3rd stage at all. Right? Now the grey hepatization stage is 5 to 7 days, that is uniformly grey, exudate full of WBCs. The WBCs have increased. There's going to be lysed RBCs and fibrin. And resolution is at the more than 8 days, that is enzymatic digestion of exudate by macrophages. Now macrophages have arrived and it is going to clear off all the debris that has been caused by the lysis of RBC and killing of bacteria by WBCs and all. So the debris that has been formed there, it is going to get cleared by macrophages. Right. So yeah, bacteria arrive in the congestion stage. Fibrin and RBCs arrive at the red hepatization stage. WBC also start to form at the red hepatization stage, but there's going to be more WBC in grey hepatization stage. It is because of that you can remember that the color change from red to grey is because of addition of more WBCs, because WBCs are white, right? White blood cells. So when you mix red color with white color, the color is going to lighten a little bit and it is going to convert it to grey. So there are lysed RBCs, and also the RBCs that were red are now getting lysed, so the red color might get a little bit lighter. And at the resolution state, there's macrophages to clear off all the debris. Lung abscess, it is a localized collection of pus within parenchyma. Mind you, not exudate but pus caused by aspiration of oropharyngeal contents. especially in patients predisposed to loss of consciousness, that is alcohol overuse, and epilepsy, or bronchial obstruction, that is cancer. Air fluid levels often seen on chest X-ray presence suggests cavitation. Can be due to anaerobes like bacteroids, fusobacterium, peptostreptococcus, or staph aureus, all those that live in the oropharynx. These are the anaerobes of the oral cavity. And also there's going to be foul smelling sputum. Where else did we see foul smelling sputum, if you guys remember? Yeah, so it was in bronchiectasis. So lung abscess secondary to aspiration is most often found in the right lung, right? Because right lung has the shorter and straighter bronchi and is most dependent part. So location depends on the patient's position during aspiration. Right lower lobe if upright, right upper lobe's posterior segment, or right middle lobe if recumbent. Recumbent means bedridden or supine. There's also going to be clubbing present if it's a chronic case of lung abscess because of the hypoxia development. So aspiration pneumonia was also due to oropharyngeal contents aspiration, right? I said there, I told you that aspiration pneumonia is mostly because of the oropharyngeal bacteria. And aspiration pneumonitis is because of the gastric acid mediated inflammation. So the lung abscess has the similar pathology. Okay. Lung cancer, it's a leading cause of cancer death, and the presentation is cough, pneumoptysis, bronchial obstruction, wheezing, pneumonic coin lesion on chest X-ray, and a non-calcified nodule on CT. So site of metastasis from lung cancer are liver, because that is it's closest to, right? So the most common site is liver. It causes jaundice and hepatomegaly. Then there's adrenals, bone, pathologic fractures, brain, and lung mets, love affective, boneheads, and brainiacs. Like you can just remember these nearby organs that are liver, adrenals, there are bone, the vertebral column is just behind the lungs, right, and the brain. In the lungs, metastasis, usually multiple lesions, are more common than the primary neoplasms, most often from breast, colon, prostate, and bladder cancer. And there's sphere of complications, all due to the mass effects of the tumor. So it can cause superior vena cava or thoracic outlet syndromes if it compresses superior vena cava. Then there's Pancoast tumor, then Horner syndrome, endocrine complications are paraneoplastic, that we'll see later on when we go through each cancer. Then there's recurrent laryngeal nerve compression, which will cause hoarseness. There's effusion that can be pleural or pericardial. The risk factors include tobacco smoking, secondhand smoke, radiation, environmental exposures like radon and asbestos, pulmonary fibrosis, and family history. See, all of these, you all know these risk factors, but you might not be aware of the radon. So radon is a most common environmental cause of lung cancer in the US. Okay, so and in many places, in office places and many workplaces too, there are radon screenings because radon is found in the basements of building. And if you remember, if you watched The Office, there's also an episode where Toby speaks about his radon and Michael just shushes him away, right? So radon is very important cause for lung cancer. Squamous and small cell carcinomas are central and often caused by smoking, right? All S: squamous, small cell, central, and smoking. And the first cancer, that is small cancer or oat cell carcinoma. The location is central. It is undifferentiated, very aggressive. Indeed, the most aggressive kind of lung cancer. It may cause neurologic paraneoplastic syndromes like Lambert-Eaton myasthenic syndrome, paraneoplastic syndrome, paraneoplastic myelitis, encephalitis, subacute cerebral degeneration, that is SCD, and endocrine paraneoplastic syndromes, that is Cushing syndrome, and SIADH. And out of these, Lambert-Eaton is very important, and Cushing's and SIADH are the most important. Right. There's amplification of MYC oncogenes. It is common and managed with chemotherapy plus or minus radiation. So neoplasm of neuroendocrine Kulczycki cell, that is, it will form small dark blue cells. It's a neuroendocrine tumor, and that is why the chromogranin A, NSE, and synaptophysin, all three of them will be positive because it's a neuroendocrine tumor. And the name itself gives it away that it is a small cell carcinoma. So on histology slides, you will see dark blue cells. These are all the dark blue cells. It will be little basophilic, not very light like eosinophilic. Okay. So small cell contains only one cancer, that is small cell carcinoma. Now the non-small cell carcinomas includes adenocarcinoma, that is in peripheral location. Then its characteristics are, it is a most common primary lung cancer. It's most common subtype in people who do not smoke and in females, because females tend to smoke less, so you can remember it that way. Activating mutations include KRAS, EGFR, and ALK. It is associated with hypertrophic osteoarthropathy, that is clubbing, and bronchoalveolar subtype. Chest X-ray often shows hazy infiltrate similar to pneumonia, but it has a better prognosis than adenocarcinoma. Right, so there's just one paraneoplastic syndrome. You can't even call it a paraneoplastic syndrome. It's just a feature of adenocarcinoma, that is clubbing. You don't have to remember anything else for this. And as we know that adenocarcinoma, adeno means glandular, like, so there's going to be glandular pattern, and often stains mucin positive. Bronchoalveolar subtype, it grows along the alveolar septa, and there's apparent thickening of alveolar walls. And there's tall columnar cells containing mucus. Now this squamous cell carcinoma, so that occurs in the central region. There's hilar mass rising from bronchus. There's cavitation related to cigarettes, that is smoking, and hypercalcemia is also there because the squamous cell carcinoma produces parathormone releasing peptide. So here you can see the hilar mass, right? It can form cavitation. It is related to smoking. Squamous cell and small cell both are related to cigarettes, and as it's a squamous cell carcinoma, you can see keratin pearls. Here are the keratin pearls and intercellular bridges, that is desmosomes. Right. I think these are the, no, that's not it. So they are just intercellular bridges, that is desmosomes. Then the fourth one is large cell carcinoma. It is situated in the peripheral regions. They are highly anaplastic, undifferentiated tumors. It has strong association with tobacco smoking and may produce HCG as well. And the HCG will cause gynecomastia. It's less responsive to chemotherapy, and it is removed surgically, and it has a poor prognosis. It's in the name that it's a large cell carcinoma, so it is going to show pleomorphic giant cells. Here are the giant cells. And yeah, in squamous cell carcinoma, you have to keep in mind this hypercalcemia. Right? This is the paraneoplastic effect. In small cell, you have to remember Lambert-Eaton and Cushing syndrome and SIADH. In squamous, you have to remember hypercalcemia. Now the bronchial carcinoid tumor, that is central or peripheral, it has excellent prognosis. The metastases are very rare, and symptoms due to mass effect or carcinoid syndromes. If it's situated in bronchi itself, it is called carcinoid tumor. But once it starts secreting the serotonin into the system, it is called carcinoid. It causes carcinoid syndrome. And bronchial carcinoma can very commonly secrete serotonin into the system. Like with other GI carcinoid tumors, it has to metastasize to release serotonin into the blood system to cause carcinoid syndrome. But carcinoid syndrome occurs early in the course of disease of carcinoid tumor if it's in bronchi. So there's going to be nests of neuroendocrine cells, and the chromogranin A is going to be positive, right, as it's neuroendocrine tumor. Small cell is also neuroendocrine, that is why it has chromogranin NSE and synaptophysin positivity. Right, so only two cancers are in the central region, that is small cell and squamous. All others are peripheral, and bronchial can be central or peripheral. And how do we differentiate each of them histologically? Small cell will have small cells, and it will be of dark color. It will be of dark color, right? And small cells are going to be there. Plus, there's going to be history of smoking, right? History of smoking, or the presentation of Lambert-Eaton syndrome would be given, like history of weakness in the proximal muscles or something like that will be given, or the history of Cushing syndrome, that moon-like facies will be given, or SIADH, so ADH will be increased, so there is going to be increased water retention and everything like that will be given, right? So something like that will lead you to a paraneoplastic syndrome, and then from that you have to diagnose small cell carcinoma from the histological slides. And With adenocarcinoma, there's going to be presence of mucin. Right? This light pink material is mucin. And large cell carcinomas, the squamous cell carcinomas are hilar, in the hilar region, but again this image is not very high yield, but you have to diagnose squamous cell again from the from the paraneoplastic syndromes like that of hypercalcemia. There can be symptoms of hypercalcemia given, like the renal stones, psychiatric overtones, all of that, right? Abdominal pain and everything. So, and calcium levels also might be given with that. So with hypercalcemia, it would be the squamous cell carcinoma, or there are more chances of it being sarcoidosis. So if it's sarcoidosis, then there are chances that CT scan will be given and you have to figure out the bilateral hilar adenopathy. But if it's given, and if it's sarcoidosis, the patient would be more likely a female, right? A black female, a middle-aged black female. But if it's squamous cell carcinoma, there might be history of cigarette smoking given, and yeah, on histology there's going to be keratin pulse like this. And also, if you think also while solving the questions, if you think that the question is pointing towards a lung cancer and there's history given that the patient is non-smoker, you can immediately diagnose it as adenocarcinoma, and it's going to be a female too, right? And large cell carcinoma is also associated with tobacco smoking as well. Yeah, in neuroendocrine tumor, that is small cell, there's going to be NCAM positivity too, that is CD56. None of the chromogranin A, NSE or cyanometaphysin may be given in the question. There might just be NCAM positivity, so you just have to remember that NCAM is also for the neuroendocrine tumors. Now the Pancoast tumor, it's also called superior sulcus tumor, and the carcinoma that occurs in the apex of the lung. And if it is in the apex of the lung, it might interfere with ton of things, because there are a ton of things in that area, like brachial plexus and superior vena cava and laryngeal nerves and everything, like brachiocephalic veins. So it can mess up a ton of things, right? And carcinoma that occurs in the apex of the lung may cause Pancoast syndrome by invading and compressing local structures. Compression of loco-regional structures may cause array of findings, like recurrent laryngeal nerve can cause hoarseness, stellate ganglion can cause Horner syndrome, that is ptosis, meiosis and anhydrosis. It can cause superior vena cava syndrome, like this one is important. And there's brachiocephalic vein too, so it can obstruct it and cause brachiocephalic syndrome, that is, it has unilateral symptoms with superior vena cava, it has bilateral symptoms. So what are those symptoms? It's just congestion of congestion of unilateral side or bilateral side, or there's arm paresthesias and weakness with brachiocephalic vein obstruction. Okay, let me just write it down. It can also obstruct compressed brachial plexus that can cause shoulder pain, sensory motor deficits, atrophy of intrinsic muscles of the hand, and it can also compress phrenic nerve that can cause hemidiaphragm paralysis. So hemidiaphragm will be elevated, something like the hemidiaphragm will appear elevated and the other side will be normal. Right. Now I said that superior vena cava was important, so now we'll discuss it in further detail. So there's obstruction of superior vena cava due to thrombus or tumor, that is Pancoast tumor. It impairs blood drainage from the head, that is going to cause facial plethora. There is just redness, and note blanching after fingertip pressure. In a neck, jugular venous distension, laryngeal pharyngeal edema, and upper extremities edema. So most commonly caused by malignancy, that is mediastinal mass, Pancoast tumor, and thrombosis from invaling catheters. It's an emergency and can raise intracranial pressure if obstruction is severe. It's going to cause headaches and dizziness. So there's increased risk of aneurysm and rupture of intracranial arteries as well. Right, because the pressure is increasing due to the obstruction of SVC, so it can cause aneurysm and rupture of intracranial arteries. Right, so where is the obstruction? Like so obstruction is here, so it is going to cause JVD and upper extremity venous distension. Right, and if it's a venous block like that of superior vena cava, it causes edema, flushing in face and arms. And if it's arterial like that of subclavian Steele syndrome, it is going to cause pain and pallor, just like arterial insufficiency in lower limbs, right? So it is going to cause pain and pallor in upper limbs. Right, so we're done with the pathology section finally, and now let's move on to the last section, that is pharmacology. And pharmacology begins with the histamine blockers, that is antihistamines, H1 blockers. They are reversible inhibitors of H1 histamine receptors and may function as neutral antagonist or inverse agonist. So let's first see first generation. That includes phenhydramine, dimenhydrinate, chlorpheniramine, and doxylamine. So name usually contains N or INE, N or INE, or N and 8. So N and 8. Or you can just remember it, these drugs. These are very common drugs. So it's diphenhydramine, diphenhydrinate, chlorpheniramine, and doxylamine. Its clinical uses for allergy, motion sickness, vomiting in pregnancy, and sleep aid. Its adverse effects are sedation, so that is why it is used in sleep aid, antimuscarinic and anti-alpha adrenergic. Second generation is important with cetirizine, loratadine, phenotidine, fexofenadine, and desloratadine. And cetirizine is the most important one. Its clinical use is in allergy, and adverse effects are far less sedating than the first generation. Now there's another drug, that is levocetirizine, that has even lesser sedating effects than cetirizine. Why is that so? Because it doesn't enter the CNS, so that is why it has less sedating effects. Now the dextromethorphan. DMR is antitussive. It antagonizes NMDA glutamate receptors, and it's a synthetic codeine analog. Has mild opioid effect when used in excess. Naloxone can be given for overdose. Naloxone can be given for opioid overdose, and it has abuse potential too, and may cause serotonin syndrome if combined with other serotonergic agents. This is very important. And what is serotonin syndrome comprises of? It is hypertonia, spasticity, autonomic instability, and encephalopathy. So now the pseudoephedrine and phenylephrine. So the mechanism of both of these drugs are activation of alpha adrenergic receptors in nasal mucosa. So it causes local vasoconstriction. So we know that alpha is for vasoconstriction, right? And so the use of vasoconstriction in nasal mucosa is to reduce the hyperemia, edema such as nasal decongestants, open obstructed eustachian tubes. And adverse effects of both of these drugs are hypertension, rebound congestion, that is rhinitis medicamentosa, if used more than 4 to 6 days. And it is associated with tachyphylaxis as well, and can also cause CNS stimulation and anxiety, that is with pseudoephedrine it is more prevalent. It's very low yield. Okay, so the next topic that we are going to see is super important in pharmacology for respiratory system. So we discussed that pulmonary hypertension has three things that are increasing, right? There's endothelin receptors that are activated because of increased endothelin 1. Then there's decreased nitric oxide, and then there's decreased prostaglandins, decreased prostacyclins. Okay, so the treatment revolves around all of them, that we have to increase and decrease certain hormones and cytokines to balance the pulmonary hypertension. So let's see one by one, and the things will get more clearer as we go through them. So the first is endothelin receptor antagonist. It competitively antagonizes endothelin 1 receptors, so it decreases pulmonary vascular resistance. So here is endothelium, from which proendothelin is secreted, which gets converted to endothelin 1. And what is the action of endothelin 1? It acts on the endothelin receptor on the smooth muscle cell, and PIP2, that is phosphoinositol phosphate, gets converted into IP3 and increases calcium eventually, which causes vasoconstriction and increased proliferation, right? This is important. It increases proliferation too. But now we give endothelin receptor antagonist, that is bosentan. It's very important drug for PHTN, right? Bosentan, and its side effects are it's hepatotoxic, so we have to monitor LFTs. So yeah, so vasoconstriction is stopped because of endothelin antagonist, right? So this stops vasoconstriction. The second is PDE5 inhibitors. We talked about this PDE in the cardiopharmacology sections too, right? So it inhibits phosphodiesterase 5, so that is going to increase CGMP, and that is going to cause prolonged vasodilatory effect of nitric oxide, right? So L-arginine gets converted into nitric oxide, and that nitric oxide is responsible for vasodilation. But how? So nitric oxide converts GTP, stimulates the conversion of GTP to CGMP, and that CGMP leads to vasodilation. And yeah, CGMP is converted back to GTP through PDE5, and we inhibit that PDE5, so it's not going to convert into GTP, and so the CGMP increases and the vasodilation increases. I'm not very sure yet, but let's just see that again. So yeah, CGMP, I was right, CGMP is being converted into GTP through PDE5, and we inhibit that PDE5 with sildenafil. Right, so if there's increase in CGMP, it is going to activate MLC phosphatase, and MLC phosphatase dephosphorylates, or it is a phosphatase, so it is going to lyse the phosphate, right? So it is going to separate the phosphate head from myosin, and if the phosphate head is getting detached from myosin, it is going to cause relaxation. So that is how this PDE5 inhibitors work. There's also PDE3 inhibitors, that is milrinone, right, which inhibits PDE3, so it inhibits CAMP conversion to ATP, and as CAMP is increased, there is going to be increased calcium intake in sarcoplasmic reticulum, and that is also going to cause relaxation. Right, so here is PDE5. Here is PDE5, and this PDE5 inhibits PDE5. CGMP increases. CGMP is going to activate the MLC phosphatase. MLC phosphatase is going to cleave the phosphate or detach the phosphate from myosin head. So it is going to get dephosphorylated, and dephosphorylated myosin and active will cause vasodilation. The third, let's just go over the theory part. So yeah, inhibits PDE5, CGMP increase, prolonged vasodilatory effect of nitric oxide. Also used to treat erectile dysfunction. So that is more popular use of sildenafil, right? Everyone knows that sildenafil is used for ED, but pulmonary hypertension was the first thing it was used for, right? Then after it was started for ED. The contraindicated when taking nitroglycerin or other nitrates due to risk of severe hypertension, because nitroglycerin and other nitrate itself is going to cause vasodilation, And if we are also giving PDE5 inhibitors, it is going to cause excess vasodilation, causing severe hypotension. Right, sorry for the delay, guys. So the third is prostacyclin analogs, that is PGI2 prostacyclin, with direct vasodilatory effects on pulmonary and systemic arterial vascular beds. It inhibits platelet aggregation. And let's see the diagram that will make the things more clear. So arachidonic acid gets converted into prostacyclin, and prostacyclin activates CAMP, right? And it's because of that CAMP there is going to be vasodilation and proliferation. Both CGMP and CAMP act in a both CGMP and CAMP act in a certain way to cause vasodilation ultimately, right? So we just have to give prostacyclin analogs, that is epoprostenol and iloprost. Adverse effects are flushing and jaw pain. This promotes vasodilation just like PDE5 inhibitors. Now the asthma drugs, it causes bronchoconstriction that is mediated by inflammatory processes and parasympathetic tone. Right? So therapy is directed at these two pathways, either to decrease inflammation or to decrease the parasympathetic tone or to increase the sympathetic tone. All this LAMA, SAMA, that is muscarinic agonist and or muscarinic antagonist and all, treats this pathway, right? And everything that is related to corticosteroids or monoclonal therapy or everything like that treats this pathway. Let's just see the diagram first. I have another diagram from the question bank that I would like to elaborate on, but let's see this diagram as well first. So there's going to be exposure to allergen. There's allergen specific IgE being secreted from the mast cells, that is on the mast cell, it is already primed. So when the second time this exposure to allergen occurs, there's going to be mast cell degranulation. So there are so many drugs that work here itself, like glucocorticoids, fluticasone and budesonide. They inhibit the formation of these cells. by inhibiting the NFK beta pathway transcription factors, right? Then there's anti-IgE monoclonal therapy. It is going to inhibit the FC region of IgE, this region, omalizumab. Then there's cromolyn that inhibits mast cell degranulation. Now, when the mast cell degranulation occurs, there's going to be inflammatory mediators like leukotrienes, histamines, and interleukins that causes inflammation and causes bronchoconstriction. Now it gets very confusing here, so that is why I prefer that another diagram that I'm going to show you guys. But let's just go through this, try to go through this. There's pro-inflammatory cytokines that act on the cell wall, I think, and secretes phospholipase A2, arachidonic acid, COX-1, COX-2, and 5-lipoxygenase. So COX-1 and COX-2 stimulate prostaglandin, prostacyclin, and thromboxane that causes vasodilation to enhance the inflammation. And now again, the glucocorticoids and steroids inhibit phospholipase A2 and COX-1 and 2. Now 5-lipoxygenase activates leukotrienes. So to stop that conversion, we have anti-leukotrienes, that is Zoleuton. Then the leukotrienes will act on its receptor, that is CIST-LT1 receptor, which is now inhibited by anti-leukotrienes, that is montelukast and zafirlukast. So there are 3 anti-leukotrienes, that is Zoleuton, montelukast, and zafirlukast. So Zoleuton will inhibit the conversion of arachidonic acid to leukotrienes itself by inhibiting this enzyme called 5-lipoxygenase. And montelukast and zafirlukast will inhibit the action of leukotrienes on the leukotriene receptors, that is CIST-LT1 receptor. If it gets activated, is going to cause mucus secretion, plasma exudation, and eosinophil recruitment. Now, also its main action is to cause bronchoconstriction, right? Here, it is going to cause bronchoconstriction. And what other things will cause bronchoconstriction? There is adenosine and acetylcholine that is going to cause bronchoconstriction as an acute response to pro-inflammatory cytokines, right? And so we have to inhibit that adenosine and acetylcholine. So we do that, we inhibit acetylcholine by muscarinic antagonists, that is tiotropium and ipratropium. And we can inhibit adenosine by giving theophylline and methylxanthines. Now we can also stimulate bronchodilation. We can not just inhibit bronchoconstriction but can also stimulate bronchodilation by inhibiting the phosphodiesterase, just like we did in pulmonary hypertension. We stimulated vasodilation. Here we can promote bronchodilation by inhibiting phosphodiesterase, by inhibiting the conversion of CAMP into AMP, right? So if CAMP is being increased, it is going to cause bronchodilation. So PDE4 inhibitors, that is roflumilast, that is just for COPD exacerbations. And then there's methylxanthines and theophylline again, which can also inhibit phosphodiesterase. Also there's beta 2 agonist that can give symptomatic relief by stimulating adenylate cyclase, right? It relaxes bronchial smooth muscle, right? That includes albuterol, salmeterol, and formoterol. So the inhalers that the asthmatic patients use, it contains this tiotropium and ipratropium, and also albuterol, salmeterol, formoterol, all that. Now let's see that diagram. So these are my notes that I made from everything that I think that wasn't in the first aid but needed to be added. Not needed to be, I added everything up in this notes that was in the question bank. So everything that wasn't in the first aid you can find in this PDF, right? And you can DM me, you can message me, or you can text me on Instagram to get these PDFs I've made for the all the systems that I've done since now, and I will keep making them as I go through each system's question bank, right? So this is, I've added the theory part, and I've added the tables, I've added the images, everything like that, right? Block wise. Yeah. So let's see the treatment of asthma. See, this diagram is much clearer and much more elaborate than that. So yeah, first of all we can give anti-Ig antibody. Which color do we want to go with, guys? It's Women's Week, right? It was Women's Day 2 or 3 days back. So let's go with pink color. So we can give anti-Ig antibody, that is omalizumab, to just inhibit IgE and just stop the process from occurring at all, right? But if the IgE is primed on the mast cells and antigen binds there, it acts through Fc epsilon R1 receptor that causes gene transcription of the mast cell, right? So glucocorticoids will inhibit that gene transcriptions of the inflammatory cells, right? And there's going to be preformed vesicles, obviously. Then when it is stimulated by binding of antigen, so all of the preformed vesicles will burst out, and that is called mast cell degranulation. So that is release of histamines, right? Mast cell when degranulates secretes histamine. So to stop that mast cell degranulation, we give chromoglycates. And if histamine in case is released, we can still prevent it by antihistamines. Now this part, the gene transcription occurs, so that will secrete phospholipase A2, right? And phospholipase A2 will go outside of the cell and will convert into arachidonic acid, and the arachidonic acid can get converted to prostaglandins, prostacyclins, and thromboxane A2 through COX-1 and COX-2, right? So the steroids, the glucocorticoids, budesonide and fluticasone, they all inhibit phospholipase A2 or COX-1 and COX-2. And arachidonic acid may get converted to leukotrienes through 5-lipoxygenase that we saw, and ziluton will inhibit that conversion of arachidonic acid into leukotrienes by inhibiting the 5-lipoxygenase. And leukotrienes will act on its receptor called cis-LT1, and montelukast and zafirlukast can inhibit those receptors. Right, if leukotrienes bind to its receptor, it is going to cause one, bronchoconstriction, second, mucus secretion, third, plasma exudation, and fourth, eosinophil recruitments. Right, so it can lead to mucus secretion, plasma exudation, and eosinophil recruitment. And yeah, it is going to act on bronchi and cause bronchoconstriction. And it is stimulated by adenosine and acetylcholine as well. So we can also inhibit acetylcholine through these muscarinic antagonists called ipratropium and tiotropium, and we can also inhibit adenosine through theophylline and methylxanthine. And theophylline and methylxanthine can also inhibit phosphodiesterase, which converts CAMP to AMP. So it is going to inhibit phosphodiesterase and increase the concentration of AMP, CAMP. And yeah, roflumilast does the same action. Okay. That is, it is PDE4 inhibitors, and so it will cause bronchodilation. Also, there are certain like anti-monoclonal therapy, anti-interleukin therapy that we should discuss. Like we talked about eosinophil recruitment, right? So there's a drug called benralizumab. That will inhibit the IL-5 R alpha receptor, not receptor but the antibody, the interleukin on eosinophil surface. And second, there's mepolizumab and reslizumab, that is going to inhibit interleukin 5. Right, so that's pretty much it. This is everything that I found extra, which was on the question bank but not on the first aid, right? So I added everything that was not in the first aid here. So this PDF becomes kind of enough if you add it with first aid. So reading first aid and this PDF can be enough, right, to cover the whole system. This is that oxygen-induced hypercapnia that we talked about. Pulmonary vasoconstriction, then vasodilation will divert blood from well-ventilated regions. Right. So there's going to be more alveolar dead space. Right. So now let's go to the theory part. Sorry. So the first are inhaled beta-2 agonist, that is albuterol, salmeterol, and formoterol. It relaxes bronchial smooth muscles. It can cause tremors, arrhythmia, and albuterol is short-acting, used for acute symptoms, that is in the inhaler. Salmeterol and formoterol are long acting. They are called LABA, and albuterol is SABA, that is short acting beta agonist. Inhaled glucocorticoids includes fluticasone and budesonide. It inhibits the synthesis of virtually all cytokines. It inactivates NFK beta, the transcription factor that induces production of TNF alpha and other inflammatory agents. So, first line therapy for chronic asthma: use a spacer or rinse mouth after use to prevent oral thrush. This is very important line. Okay, so it inhibits the synthesis of virtually all cytokines. It mostly inactivates NFK beta, that is a transcription factor that induces production of TNF alpha and other inflammatory agents. So first line therapy for chronic asthma. So there will be questions where the patient will present with oral thrush or whitish membrane in the oral cavity, and upon taking history it will be given that the patient might have asthma from younger age, or a patient has to use inhaler for some condition or something like that, or patient gets allergic very often, right? If he is exposed to certain allergens, he gets allergic to them. So you have to diagnose asthma from that, and you have to figure out that he may use a spacer and then doesn't rinse mouth after using that spacer. After using that inhaled glucocorticoids. So muscarinic antagonists include tiotropium and ipratropium. It competitively blocks muscarinic receptors, preventing bronchoconstriction. It is also used for COPD. And tiotropium is long acting, that is LAMA. Ipratropium is short acting. Now the anti-leukotrienes, that is montelukast and zafirlukast. So we just saw that it prevents binding of leukotrienes to its receptors. So basically it inhibits the leukotriene receptors, that is cis-LT1. Especially good for aspirin-induced or exercise-induced asthma. And Xileuton is 5-lipoxygenase inhibitor. So it is decreasing the conversion of arachidonic acid to leukotrienes itself, and that is hepatotoxic. Anti-IgE monoclonal therapy is omalizumab, binds mostly unbound serum IgE and blocks binding to Fc epsilon Ri. It is used in allergic asthma with increased IgE levels resistant to inhaled glucocorticoids and long-acting beta-2 agonist. Yet, patients that are resistant to inhaled glucocorticoids are started on omalizumab. Now, the next one is methylxanthines that are theophylline. You have to remember this term too, right? Methylxanthines. That theophylline is a kind of methylxanthine. Likely causes bronchodilation by inhibiting phosphodiesterase. That is, it increases CAMP levels due to decreasing CAMP hydrolysis. So limited use due to narrow therapeutic index, that is cardiotoxicity and neurotoxicity. It can cause cardiotoxicity and neurotoxicity. It is metabolized by cytochrome P450 and blocks action of adenosine. Just here we saw that here was theophylline inhibiting adenosine and phosphodiesterase 4. Next is PDE4 inhibitors, that is roflumilast. It inhibits phosphodiesterase again, increases CAMP and causes bronchodilation and decrease airway inflammation. It is used in COPD to reduce exacerbations. Now the chromones, that is chromoline, it prevents mast cell degranulation and prevents acute asthma symptoms. It is rarely used. And the last is anti-IL-5 monoclonal therapy. It prevents eosinophil differentiation, maturation, activation, and survival mediated by IL-5 stimulation. So for maintenance therapy in severe eosinophilic asthma. Right, and the examples are mepolizumab, reslizumab against IL-5 and benralizumab against IL-5 receptor alpha. Right, so it is mostly useful in the eosinophilic asthma. Right, so I guess that's it. We are done with the respiratory system. And yeah, you guys can, if you are watching this and you are interested in those notes that I made, you can DM me on my Instagram handle, right? So my Instagram handle is, as you know, is it's given in the channel description. It's step1 mavericks, right? With the underscores between step and 1 and 1 and mavericks, right? So I'll just write it down here. Step 1 mavericks. I should highlight it too, right? Right, so see you next time, guys. I'm going to upload the endocrinology section too pretty soon, like within a few days. It won't be another 6 months delay in doing that, right? Okay, so good night. It's like 2 a.m. here, so I might sleep too. Good night, guys.